share with us some very, very interesting cases. share with us some very, very interesting cases. share with us some very, very interesting case. share with us some very, very interesting case. share with us some very, very interesting case.
5 seconds.
Okay, but I don't see it on the screen.
Dice que no ve la pantalla.
Ahí estamos.
You can start to talk now.
Okay.
Dr. Stoll.
Yeah, ladies and gentlemen, it's a great pleasure that we can welcoming you on this section on interactive cases. We have a very distinguished panel here and a very distinguished speakers. And we will start with 4 cases from Ruža, from Croatia. And so we now see these 4 cases. And after these 4 cases, we made the discussion.
Hopefully to start in a minute. Yeah, thank you very much for your introduction. I'm very pleased and honored to be in this kind of the great company of the experts, and I'm going to present you 4 cases. Hopefully you will find them very interesting. My name is Ružica Jurakić-Tončić, and I work at University Department of Dermatovenerology at University Hospital Center of Zagreb. First case is a female child. She's 3 years old and with a medium-sized congenital nevus, which and the mother observed a recent fast growth of the black nodule. So this is the endoscopy of the lesion. As you can see, in another part of the lesion, we have a bluish structureless lesion, and we have black dots, and we have blotches also. As you can see at the periphery of the lesion, there is also black blotch, and there are some black dots dispersed on the lesion, and also there is a region of regression. So, what are your differential diagnosis and the management? 1, everything is fine and you will send the patient and her mother home. 2, your diagnosis is melanoma in congenital nevus. 3, your diagnosis is proliferative nodule. And 4, you will do the biopsy because you don't know what a diagnosis is. Please vote. Okay. So it's getting me back on the start of the, just a second. The correct diagnosis can be obtained only after histology report, and the correct answer is number 4. Why? In fact, this is a melanocytoma in congenital nevus, and the diagnosis was made in a collaboration of 2 independent expert centers. In fact, this was melanocytoma and in conjunction with a young junctional melanocytic nevus. At the end of this case, not just that I want to remind you that the differentials in newly occurring nodules in this kind of the lesions can be among them also melanocytoma. I would like to invite you to join our active study of IDS, because the active study of IDS is still going on, and it is regarding prevented epithelioid melanocytoma. Please send out your cases and join us. Case number 2, also again case of the birth mother with a child. This is 23 years old female patient, and she presented due to new fast growing lesion, which presented as a typical macule on her toe, which occurred 3 months ago. She's otherwise healthy. As you can see, this is a small lesion. This is a lesion in a diameter of 3 over 2.5 millimeters, but presenting with a parallel ridge pattern. So, What is your differential diagnosis and the management? 1. You think this is a nevus and everything is fine, and you will send the patient and her mother home. 2. You diagnose melanoma and you will perform urgent excision. 3. You think everything is fine, this is subcarinal hemorrhage. Or 4. You think this might be a Spitz nevus. Please vote. Excellent. Well, the correct diagnosis is plantar typical Spitz nevus. Again, the histology was the one who gave us correct diagnosis. This is a case where I wanted to show the parallel-ridge pattern, even though it is highly suggestive for melanoma and carries huge diagnostic accuracy. You have to be aware that there are exceptions to the rule of the parallel-ridge pattern, such as repetitive trauma, congenital nevi, exogenous pigmentation, subcurrent hemorrhages. And please do not forget that a Spitz nevus is also a differential diagnosis. And this is no surprise to us that melanoma can be similar to Spitz nevus even in this kind of the lesion. Again, case 3. This is a solitary erosive lesion on an alanasia of the male patient. This is an adult patient in a middle age. This is a long-standing lesion which is periodically healing. During the examination, it was covered with a crust. There were no other suspicious lesions. So what should we do? So here is the dermoscopic image. As you can see here, there is an erosion, part with quite a small erosive part, also a hemorrhage. There is also a wide structureless area, and there is also ulceration. So, after the dermoscopic image, what are your differential diagnosis and the management? 1, you think dermoscopy is helpful, and you think this is benign, and you will send the patient home with antibiotic ointment. 2, dermoscopy was helpful, you think this is a BCC. 3, dermoscopy was helpful in a way that you know that this is not a BCC, and since you don't know why, you will do the biopsy. 4, you will not use your dermoscope at all, since you are sure about your differential diagnosis. Okay. Well, the correct answer was number 3. In this case, dermoscopy was not diagnostic, but helpful in ruling out the other diagnoses such as tumors found in this region. Since we found no criteria for neoplastic disorders, we searched for other diagnoses causing erosion on the skin. So this was a case of and proof that sometimes common diagnoses present themselves in an uncommon way. In fact, this was a case of a patient who presented with the pemphigus vulgaris, and this was the first lesion that we observed. Also, we have to be aware that knowledge of dermoscopy of other skin disorders are also raising, and there are papers covering knowledge on this part of the dermatology. And the last case, very simple one. This is a female with a 56 years old, and she has a slow-growing lesion over a long time on her right thigh. This is a huge lesion because this is almost 2 centimeters over 8 millimeters. So this is a dermoscopy. As you can see, majority of the lesion is pinkish. So you can see this is a milky red, this is structureless, but there are also some here scaling. There are some pigment structures. Much more majority of the pigment is observed on the lower part of the lesion, so we can even call this kind of the pigmented structures blue ovoid nests. This is also an ulceration, and if we observe the lesion on the lower magnification, there is also a little bit of the light brown structureless area. So you think this is a melanotic melanoma, you think this is a dermatofibroma, you think this is a BCC, or you think this is some kind of the collision lesion. Please vote. Okay, excellent. The correct answer was number 4. In this case, dermoscopy was diagnostic and helpful. We found criteria for BCC and we suspected dermatofibroma because I did not say that the lesion was hard on probation. In fact, this was a confirmation that we had a collision lesion. In fact, in one lesion, we had elements of the BCC and dermatofibroma. So as you can see, sometimes a lesion can present as a collision lesion, and in this kind of cases, dermoscopy can be very helpful. At the end, I would give thanks to my colleague and send my regards and say that they are beautiful co-workers, and also thank you for your attention.
Yeah. Thank you, Rusa.
Thank
so
you.
This were very good cases, and not so easy for the diagnosis. And I think there is enough room for discussions.
Well,
and
I'm ready for questions.
And questions, yes, of course. Can we go back to the first case? So maybe we can discuss the case. You can keep sharing the screen, and we can discuss the cases together with the dermatoscopic image. This would be great, I guess.
The first case was melanocytoma in congenital nevus.
Yeah.
It was a medium-sized congenital nevus. I have to tell that I had the experience of 2 melanocytoma in last 6 months, both presented in children. Therefore, I showed you just the first girl because she was more, let's say, typical. And of course, the mother was very worried because the nodule was growing very fastly in a few months. To be honest with you, I did not think about any kind of melanocytoma when I saw this kind of the lesion. So at the end, when the histology came, I have to say that I was a little bit relieved, but also this caused a huge amount of the stress, because when you read the literature regarding melanocytoma, there are not many papers which will tell you what in fact to do with this kind of the patients. And of course, if you discuss with the pathologist and ask them, okay, can you explain me a little bit of melanocytoma and what should I do as a clinician, then you get a lot of controversies. And in fact, I was facing a lot of problems, to explain the mother what in fact melanocytoma is. So maybe I would also be very pleased to see whether you had any kind of the experience with this kind of the patients, and how do you see melanocytoma, and what would you suggest to do with this kind of the patients, and how many experience personally you have with them?
So I think melanocytoma is a very complicated histologic diagnosis, and if you read the literature, there are also two ways of thinking. I think for the audience we have today, the most important point is, as already Elvira Moscarella yesterday pointed out, you have a mole, not so large mole, a small congenital mole. You have a change in this mole. You have blue-gray areas with whitish area next to it and a little bit bluish area down also at 5 o'clock. So definitely you have to act. Yeah, you have to make a biopsy. So I personally do not know the criteria to differentiate for sure between melanocytoma and melanoma. Proliferative nodule is the other option, so you have to make a biopsy. So that's the teaching point, or our first teaching point, I guess. What's about the panel? Do you have comments on that?
I would like to comment.
Tracy?
I was just going to say, I wanted to totally agree with you. You know, seeing, under the polarized dermoscopy, we're seeing those white shiny lines. Dermoscopically, you have to biopsy something like this. I couldn't just leave that alone. But I think that the pathology really is going to be the most helpful in this case. But I think the main point is, you see that, the color, the white shiny lines, it buys you a biopsy.
Yeah, in fact, we did the excision of the entire nevus because it was a region where we could do that because it was on a tie of the child. So a lot of skin, a lot of healthy skin, which was elastic. So we did that, So the pathologist had entire lesion, and in fact, a lot of a lot of experts were discussing, it is a child, and it's not easy to give a diagnosis of melanoma to a child,
Yeah.
But in fact, I had 3 melanocytomas in the last 2 years. So with this diagnosis, I'm still not feeling very comfortable because, this is like some kind of the gray zone, but nobody says, okay, precisely you have to do that.
Yeah.
And there are no guidelines for the follow-up to these kind of the patients. So there's always a question: should you do, sentinel lymph node biopsy or not? Of course, it's a child, so you will not do that, but we're liking the guidelines. This is the reason why I discussed with Gerardo Ferrara and with Professor Giuseppe Argenziano to make an idea study to collect the patients, to collect the knowledge, because these kind of the lesions are very rare. So the knowledge is very limited. So therefore, I will call all the colleagues around the world who have this kind of the lesions to send out our cases, because the more cases we see, the better the knowledge will be. Of course, there is I have to say it's another gray zone in melanocytic biology.
That's great. Did Gerardo agree with the diagnosis of melanocytoma?
Yeah.
Okay, so what's the opinion of the other?
I would like I would like to say really, it's a great case, Ružica. So I pronounce your name rightly, and and really rare case and unique. I haven't patients with this diagnosis, so it is for almost all of us the new one, and it is very important to know the dermoscopic features. Of course, we should excise the blue lesion developing and elevated, but this diagnosis is very interesting, and I'm looking forward to your study.
Yeah, thank you very much. Hopefully we will get more cases.
Yes.
And Pablo and Pedro, any comments?
Totally agree.
Yeah, I totally agree with them.
Okay.
And, but I'm not sure what to do with this guy, with this child. So I remember one case but not over a congenital nevus, and a couple of cases really, and we treat them as melanoma finally, because suppose that melanocytoma is a kind of low grade, something like that. Some people think that melanocytoma have potential. It's kind of low grade melanoma. Well, I'm not sure what low grade melanoma is, but they think that it's a melanoma with.
Yeah, I'm closely following up this child on a 6-month basis, and I'm doing ultrasound of the regional lymph nodes.
Yes.
In fact, this is the, let's say we have melanoma, some kind of the, when we deal with this kind of the patients, we always do it together. We discuss, you know, so it's not just my decision how to deal with this patient and how to follow up them. We do that with also typical Spitz nevus with all melanoma patients. We have a collaboration of the colleagues who are dealing with melanoma, and then we consult, and then we together make a decision how to follow up these kind of the patients.
Do you have any molecular genetic data, NRAS mutation, next generating sequencing, anything there of that, or BRAF mutation?
Probably the pathologist did that, but it was not stated in the histology report. Okay. So I'm not aware of the genetics mutations, but I can ask. This would be very interesting to know, in fact. Yeah.
Okay. So then we continue to the second one. As I can see from the website, there are no questions, but I am not sure whether they are updated. So I do not see any questions. So this is the next one is a fantastic case, parallel ridge pattern, very simple, and you pointed out the exception to the rule, and yeah, it's a very good case showing that there are no exceptions. There are always exceptions, sorry.
Yeah, this was also a case with a very, very worried mother. You know, when it comes to the moms, they're very always, you know, it's huge stress when you have this kind of the patient, of course, and this patient has a mother. So I had 2 worried mothers. It happened precisely at the same time. So a lot of worry on my mind, you know. But in fact, this was also a very strange lesion, and a lot of discussion among pathologists was done. And in fact, also this was done by Gerardo Ferrara. Okay. So when it comes to typical Spitz lesions, it's very strange. And in fact, this was the first description of a typical plantar Spitz nevus. So we published that. This is also, I think, very demonstrative, because I think that you have to always take in consideration that when it comes to the differential diagnosis, Spitz nevus always is mimicking melanoma, in fact. So this is my point, teaching point of this case. Dermoscopy is very simple. You have a parallel ridge pattern. There is no discussion. When you see this is, I mean, worrisome sign, and you have to excise this lesion. And exactly we did that.
Pedro, do you have any comments for that case?
No.
No. You are satisfied.
It's a very interesting case because it's a clear parallel ridge pattern. Okay, and you can diagnose this case as melanoma, but we know that Spitz nevi can share the features, dermoscopic features with melanoma. Okay, Spitz nevi and melanoma. Yes, it's very interesting.
And Tracy?
You know, looking closely, I guess I was wondering, just kind of inferiorly, it almost to me looked like a little bit of like a thick fibrillar pattern. So like if you look kind of like at the edge, so in that way, you know, is it kind of a little bit of a fibrillar pattern, and then thus it's less worrisome? I mean, I think I see at the top here.
This was a lesion which grew in 3 months. So it was strangely growing, fastly growing black lesion, very atypical clinically. And she was 23 years old. Therefore, we were also discussing, because, you know, this is a very small lesion. It's 2.3 over 3 millimeters. So it's not a huge one. Therefore, we always also discussing, okay, is it a parallel ridge pattern? I thought it was, but we were just thinking maybe it's not. we have to excise it nevertheless, because it's a very strongly, fastly growing lesion, newly developing, and it's definitely ugly duckling sign, So we did the excision. I have to say that, atypical Spitz nevus was very surprising diagnosis for me, but better for the patient. Yeah.
So, Danica?
Thank you, Professor Rurica. Now you told us that this was around 2 millimeter, 2 or 3 millimeter lesion. I would like to.
Yeah.
I'm sorry.
2.5 over 3
Okay. So I would like to point out the diameter of the lesion, because some of the dermatologists are still relying on a rule, 6 millimeter on acral skin. So if we find, we see the parallel ridge pattern, we don't rely on a size, so we excite it. I think that we all agree with this. So if we find a parallel ridge pattern in a small lesion like this one, we should excite it, not follow up.
Yeah.
And Pablo, you would like to mention something? No,
it's a really interesting case, and I would have excited if because it's a parent pattern and maybe an atypical fibral pattern in combined. So, and in an adult with a growing lesion. So yeah, and happily for the patient was Spitz nevus. So
yeah. So then we continue with the third case.
The third case, and this was, I was thinking maybe I should not put this patient this case because dermoscopy was not very specific. But then, sometimes the common diagnosis in dermatology present in an uncommon way. Of course, this is the first case of pemphigus vulgaris which ever occurred on Alenazzi, and it was occurring as a solitary lesion which was recurring and healing. So therefore, I was just, showing you that sometimes, the books are, the diseases are not reading the books, and sometimes we really surprise ourselves after the diagnosis. So maybe this was a little bit confusional, but I think it's also interesting to show.
Yeah, that's very interesting. So I have a rule: if there is an ulceration on the face in elderly skin, and also if you do not see clear features for BCC, it's always suspicion for BCC, and definitely one has to perform a biopsy. So, but I did not think on pemphigus. But now, if you look at the image, you see at 9 o'clock there is a small step in the skin. You see the normal epidermis, and then you see the small erosion at 9 o'clock. And maybe on this side, this is the clue. But I realized this only after knowing the diagnosis.
Yeah,
so
it was surprising for us even,
And that time, did you do full total skin examination or just?
Yeah. We always do that.
Did the patient have anything else?
No. This was
not at all.
A solitary lesion, nothing else, completely healthy. And he says, okay, doctor, this is the lesion who is coming and going. It's presenting and healing, and I don't know what it is. And of course, he came to the clinic, and then we were seeing, the patient said, okay, it's ulceration, it's erosion, but we are not sure what it is. So we decided to do the biopsy. And after the biopsy was done, and the histology was seen, you see the acantholysis, and then of course we did the antibodies against the desmoglein, and then you have a confirmation of the diagnosis. Of course, the patient after that developed the full-blown disease, and everything was clear. But sometimes you are at the beginning, and the patient is presenting itself like this. It happens, and you have to be brave to think other diagnoses. But in fact, what we did see in the dermoscopy, that you didn't have any kind of the confirmation of we did not see any kind of the typical vessels. So we are thinking, okay, it's probably not a tumor, but wow, who can tell without a histology? So this is, of course, common dermatological disorder presenting in an uncommon way. So, yeah, in fact, if you read the papers on dermoscopy of pemphigus vulgaris, in fact, this is a perfect case to study, because they say you see the ulceration, and you have this is the region of acantholysis, which is presenting with a white color. You can see some kind of the vessels, but they're not presenting as a typical vessels. So, in fact, this was a case of pemphigus vulgaris presenting a nose.
So, Pedro, you are the expert for rare cases. Adnexal tumor?
But this is very rare. This is very rare. I have to
Poroma.
admit that I wouldn't have diagnosed this case clinical, but dermoscopy is very difficult too.
Okay.
Yeah.
No poroma.
No poroma. No.
Okay. So, Pablo, what's your opinion? Unusual case.
It's a great case, and but I did think in a blistering disorder, and because of the erosion at 9, and
Okay.
I couldn't, because I didn't see any features of BCC, or
Okay.
and I wasn't sure about SCC, but yeah.
Danica?
Unusual, really unusual dermoscopic image. Really, don't have a clue.
And Tracy? What's about Tracy?
Yeah, I agree with you that, whenever I see an erosion, a lot of times, even if I don't see the actual vessels of concern, I wonder, is there something underneath that I'm missing? So I definitely agree. I would have been worried about some sort of, non-melanoma skin cancer in this case, without any other erosions anywhere else to give you that hint of the pemphigus.
Okay. So we have one question for the case before, and this is a quite interesting question, and it's mainly a question regarding histopathologists.
Okay.
How can you differ the plantar spitz nevus with acral melanoma in situ in a child? How did you take the biopsy? Okay, you did the full excision.
Full excision of the full excision of the lesion, and I believe that I'm not the kind of the expert which can say this, answer this question, because this is pure histology. Yeah. So this is the reason why I also put the histology here on the slide, because nevertheless, if you ask me how did they differentiate it, this is way out of my expertise. I would like to be more familiar with the histopathology, but I suppose I'm a pure clinician, so this would be demanding a lot of histopathology lessons. And I think even between the pathologists who are dealing with the melanocytic lesion, there are among them people who are more familiar with the spitzoid lesions than the others. So I think that this question, I will be very grateful to thank the person who gave it to me, but I'm not capable of giving proper answer. But this is histology, and this is also not done by one histologist. A lot of people discussed it because it was strange, and a lot of discussion was made also with Gerardo Ferrara and with the entire pathology department of University Hospital Center of Zagreb. So two centers were speaking a lot, and a lot of pathologists were involved in this kind of diagnosis.
Yeah, that's true. So we are reading histopathologists, and I do it myself every day. And I know Gerardo very well, and if he says it's a Spitz, I trust him. So you can present these cases on histopathologic conferences, and you can discuss for a long time. I cannot see it very well, but
this is not
the major feature, the most important feature is symmetry and orientation of the nests, and less single cells in higher layers of the epidermis. So, but if Gerardo says this is a Spitz nevus, we can trust him. So then we go to the next case. This is the fourth one. So we had, in interest of time, we have to speed a little bit up. So this is an interesting case, and
yeah, we were sure.
On forehand, what was your first diagnosis prior to histology?
Yeah, we were sure about this part for stating that this is a BCC, but we were not practically sure about this because the clinical impression was more for dermatofibroma. It was hard on palpation, but in fact it was a huge lesion. It was a lesion which was almost 2 centimeters in one diameter. So we were speaking, okay, well, and it was also a long-standing lesion. It was tiny, so. But we were speaking a lot, but then we said, okay, maybe we do have a collision, yeah, but we were saying, okay, this is a BCC. So some kind of the strange version of the BCC, but then you have a histology and then you have everything. Just you have a collision of 2 lesions, you know, you have a pure confirmation that it's a dermatofibroma and you have a BCC and there is no discussion regarding that.
Yeah, and maybe can we go one back? So this is quite interesting because you have 2 parts of you have the dermatofibroma, you have the nodular BCC, and at the epidermis you have these basolead proliferations, and these basolead proliferations from the epidermis you can see often in dermatofibroma, but they belong not to the BCC, but you have definitely a nodular BCC. So this maybe explain also these brownish spots in the other parts of this lesion. So Tracy, what you would like to comment?
Yes, if you go back to the image, so the things that really clued me into the fact that it was a BCC. So superiorly, it looks like there's kind of like concentric structures. So like darker pigment in the center and then a little bit lighter around the side. And I thought that the ones that the brown lesions inferiorly did look like nests. I was having trouble seeing the blood vessels. So kind of in the middle, I wasn't sure if those were going to be some dotted vessels or something, which would not go with the BCC, but the pigmented areas really kind of clued me in.
Yeah.
And Pedro published many cases of collisions. So
yes, we have recently published many cases of malignant collision tumor. At least one of the parts where malignant endoscopy has demonstrated to be very useful in the diagnosis of these malignant collision tumors, because sometimes, not in this case, because clinically you can see something suspicious, but sometimes you can see the malignant part of the lesion hidden in the benign part, because if the predominant part of the collision tumor is the benign part, the malignant part, don't worry, because you are going to diagnose the lesion as malignant and you will excise the lesion, because if the predominant part of the lesion is the benign part and the malignant part is hidden in the benign part, is very dangerous, because we can misdiagnose the lesion as benign with all the consequences that would entail. But dermoscopy has demonstrated to be very useful in the detection of these hidden malignant tumors inside the benign predominant part.
Anitza?
One question.
Sorry.
Question, but we have consumed more than 2/3 of the session.
Yeah, that's that.
I have this very interesting.
No. I have this in
I'm
my
sorry
eye.
to say that. Sorry.
No, we have in total 7 cases and 3 to go. So therefore, I made this decision. Otherwise, so Danica, you would like to add something, or?
No, I have some cases similar like this basal cell carcinoma, not collision, which looks not so typical for BCC. So it could be maybe also interesting for publish this. I'm not speaking about collision tumor, but this kind of unspecific basal cell carcinoma, not typically looking like. It could be also interesting. Only this.
Okay, so. And Pablo, you are fine with the discussion in yeah, beautiful. So Pedro, you have only 1 case, I guess.
But a complex case with several
Okay, sorry about this. I did not know this. So we continue with Rosario. So sorry about this, but I thought there you have only 1 case. Okay, so sorry.
Okay.
So then we speed up. So Rosaria, please show us your 2 cases.
Okay. Wait a minute. let me know if you see my screen.
Yes.
Yep.
Yes. Okay. Well, hello, I'm Rosario Peralta from Argentina. It is my pleasure to be here with you. I have two cases. This is the case number 1. Wait a minute. Okay. This is a 41-year-old female patient with atypical mole syndrome and family history of skin cancer, both parents with BCC. Oh. Well, in the clinical exam, she presented on the right arm 2 pinkish lesions, the lesion with continuous growth. The lesion A was a pink plaque measuring 1 centimeter in diameter with a smooth surface, irregular borders, and a small area of brown coloration. Lesion B was a pink plaque measuring 4 millimeters in diameter with irregular borders. This is the dermoscopic view of the both lesions. And with these pictures, what do you think about the possible diagnosis? Now you can vote. Do you think that it could be an ECC plus BCC, 2 BCCs, and amelanotic melanoma with BCC, or amelanotic melanoma with SCC? You can vote now. Well, one more second. Okay, all of you think in the option number 3. Wait a minute. I'll share again my screen. Let me show you now again. This is the dermoscopic picture. Here we can see a pinkish background with a polymorphic vascular pattern. This is a big clue. We have irregular distributed dotted vessels, but also in the left part of the lesion, you can see hairpin vessel, a linear irregular vessel, and also a corkscrew vessel. Also, it presents brown focal pigmentation in the middle of the lesion, a negative network, and shiny white streaks. The histological analysis revealed in the left side of the image, we can see the wait a minute. We can see the growth part of the lesion, and in the right side we can see the atypical melanocytes in the epidermis. This lesion was an 1.5 millimeters Breslow melanoma. On the other hand, we can see the dermoscopic characteristics of the lesion B with a pinkish background. And here we can see superficial fine telangiectasias, multiple small erosions, and shiny white streaks. The histological analysis revealed characteristics of superficial BCC. So the final diagnosis was hypomelanotic melanoma and superficial BCC. Now I want to share some comments with you. You know that pink lesions are a really challenge for physicians, and due to the lack or little pigment, the vessels become the key to diagnosis. It's important when analyzing a vascular pattern, the morphology of the vessels, the distribution pattern must be determined, and if you have only one type or different type of vessels. This is the monomorphic or polymorphic pattern. Amelanotic melanoma, it's very rare. It's more common to see hypomelanotic melanoma, and these melanomas present three main features: vascular structures, remnants of pigmentation, areas of regression, and additional clues. Related vessels, dotted vessels, which are highly predictive of melanocytic tumors, are presented in thin melanomas with regular distribution. The linear irregular vessels are more common to see in thick melanomas, and the most frequent pattern for diagnosis melanoma with high specificity is the combination of dotted vessels and irregular vessels. Finally, we can see milky red globules or areas, more in thick, principally in thick melanomas. Remnants of pigmentations are usually present, and the most important predictor of melanoma is the irregular depigmentation. Areas of regression of blue-gray dots, large white areas, and blue-whitish base are also present. Additional clues include shiny white streaks and negative pigment network. These structures are not pathognomonic of melanomas. The shiny white streaks, which are seen with polarized lines, we can see also in dermatofibromas, scars, BCC, and Spitz wreaths, nevus, and negative pigment network in dermatofibroma, melanocytic nevus, and Spitz nevus. It's important to remember that Spitz nevus also present regular distributed dotted vessels. So in such all that cases, it's better to remove the lesion for histological analysis and rule out melanoma. Concerning the dermoscopic features of the no-pigmented superficial BCC, remember that are characterized by superficial fine telangiectasias, multiple small erosions, shiny white red structureless areas, and shiny white streaks. The differential diagnosis includes skin tumors like Bowen disease, that presents dotted and glomerular vessels arranged in clusters with whitish scales or yellowish scales, or inflammatory skin diseases like psoriasis that present regular distributed dotted vessels with white scales. Let's continue now with the case number 2. This is a 12-year-old female patient who presented a red nodular pigment lesion, which was firm, located on the back, that appeared 2 months ago with progressive growth. This is the dermoscopic view of the lesion with this picture. What do you think about the possible diagnosis? Now you can vote if you think angiokeratoma, amelanotic nodular melanoma, pyogenic granuloma, or nodular Kaposis sarcoma. Okay, perfect. Let me show you now. You are correct. And here in the dermoscopic picture, we can see reddish homogeneous areas and these beautiful white rail lines like a double rail. The histological analysis revealed a tumor with vascular proliferation and fibroseptations. Well, the principal structures for pyogenic granuloma are reddish homogeneous areas, white colored surrounding the lesion, white ray lines, and ulceration. Vascular structures can be present also as datid, harping, linear irregular, or polymorphous vessels. Concerning the pattern studied, reddish homogeneous area, white colored, and white ray lines showed a specificity of 100%. But it's very important to remember that from the dermoscopic point of view, none of that structures are specifics for pyogenic granuloma, and we can see them in melanomas. So if you see a red tumor, like in these pictures, resembling a pyogenic granuloma, and especially if it has vessels, bleeding, or ulceration, remember that histopathologic confirmation is recommended to rule out an amelanotic nodular melanoma. Now I want to show you this case of an nodular melanotic melanoma, which presents a polymorphous vascular pattern with linear irregular vessels, with these milky red globules and areas. And we can also see the blue whitish veil, ulceration, and notice these textile fibers on the tumor, which represent an indirect signs of the ulceration. So, summarizing, pyogenic granuloma has it's very high specificity when present reddish homogeneous area, white colored, and white ray lines, while the clue for the amelanotic nodular melanoma is on the vessels, and as these tumors grow, increase the vessel polymorphisms and ulceration. Thank you very much for your attention.
Yeah, Rosario, this was an excellent presentation. Thank you. And you pointed out very well the differences in the vessel type. So I'm very sorry to Pedro, but I did not realize that cases are more. And so, but at the end, your paper was cited, so your famous paper. So maybe Rosaria can manage that we get 5 minutes more from.
Yes.
From the
you can comment as you want. I think that it was it has lots of information, educational information, no, to make easy to remember the clues, the principal clues, and bueno, I let you advance with the comments.
No, that was a beautiful presentation. So Pedro, now you show us your complex case, please. And hopefully we get 5 minutes or 10 minutes more to discuss it in detail, your case.
Okay. Okay. Well done. Hello. Everyone, I'm Pedro Zaballos from Spain. I'm very glad to be here with all of you. First of all, I'd like to thank the Scientific Committee for inviting me to this virtual World Congress of Dermoscopy, which is very, very interesting, isn't it? And well, I'm going to share with all of you an interesting but difficult case. Okay. And this is a 71-year-old woman with this medical history who presented with 10 asymptomatic pinkish papules and plaques located on the trunk, but mostly on extremity, as we can see here. She had noticed the first tumors 3 years before, and these tumors had gradually increased in number. Okay, here we can see the dermoscopic images of 4 of these lesions. Let's see the dermoscopic image. This is the first. All the lesions were removed, and all the lesions are the same tumor, the same kind of tumor. This is the first dermoscopic image, who belongs to a lesion located on the right arm of the patient. Okay, subtle structures. Let's see the second dermoscopic image, who belongs to a lesion located on the left thigh of the patient. Less subtle structures. The third dermoscopic image tumor was located on the right thigh of the patient. Okay, don't worry. Let's see the fourth dermoscopic image, who belongs to a lesion located on the left thigh of the patient, where we can see these peculiar vascular structures. And finally, the fifth lesion was located on the lower back of the patient, okay, where we can see these, well, curious vascular structures. Okay, it's time to decide, time to choose. What's your diagnosis? What's your guess? Is your A, inflamed seborrheic keratosis, apocrine poromatosis, cutaneous metastasis, or sebeciomas? Perfect. Yes, yes. Okay. So, yes, the most important finding or clue in my view in this patient are the presence of these peculiar vessels, branched vessels with rounding endings. I mean these loop or coiled terminal endings. And are they the sebeciomas? Okay. Well, sebeciomas, as you all know, are usually located on the face, not on the trunk or extremities. The dermoscopic appearance is different from that, and a group of friends have collected a big number of sebeciomas, and none of them had this peculiar vascular structure. So, no. Are they cutaneous metastases? Well, the patient was an elderly woman with skirted pinkish lesions located on the trunk and extremities. It could be 3 years. Okay. As you all know, cutaneous metastases can display different vascular structures, but unless stated otherwise by Danica, okay, in their interesting forthcoming article, I think that cutaneous metastases don't usually show these peculiar vascular structures. Okay, what about inflamed seborrheic keratosis? We have recently collected and studied a big number of inflamed seborrheic keratosis, 230. Only one lesion, one inflamed seborrheic keratosis displayed these peculiar vascular structures, these branched vessels with rounded endings. So it's very unlikely these lesions to be inflamed seborrheic keratosis. Okay. However, in our case, 8 out of 10 lesions of the patient had these curious vascular structures, these branched vessels with rounded endings, as we can see here. If you like metaphoric language, you can find in the literature names like cherry blossom vessels, flower-like vessels, floral vessels, calyx-like vessels, or leek-like vessels, referring to the same structure. Okay, I prefer these branched vessels with rounding endings. Okay, my view, but okay. What else can we see in this tumor apart from branched vessels with rounded endings? We can see, look at this right part of the lesion where we can see these interlacing hypopigmented or white areas or bands, okay, here, and surrounding vascular structures, okay, which have been also named in the literature as interlacing white cores, mesh bands, frog egg appearance, etc. Okay, prefer interlacing white areas around their cells. Okay. And what kind of tumors can display these two structures. Perfect. Okay, most of the audience choose poroma. And here we can see the histopathologic correlation of one of these lesions, where we can see these cords, okay, of neoplastic poroid cells connecting epidermis and extending into dermis. Okay, here in this slide, we can see a possible explanation. We can see a possible explanation of these branched vessels with rounding endings. I'm merely speculating, but could be, okay? And perfect, again, now we can see another histopathologic correlation of the third lesion. And we can see these large and small dots. And finally, the histopathologic correlation of the fifth lesion of this plaque located on the lower back of the patient, where we can see these groups of sebocytes. I agree with Emilio's and co-workers in their articles. Poromas are very difficult to diagnose, even with dermoscopy, because they can mimic, well, every benign and malignant tumors, as we can see in the images of their article. But they also stated that this peculiar flower-like vascular structure is very useful in the diagnosis of poroma. Later, Marchetti and co-workers stated that the presence of any of these 5 features was associated with a sensitivity and a specificity of 62% and 82%, respectively, for poromas. Branched vessels with rounded endings was, well, quite common, and 30%, okay, here. And useful in the diagnosis of general poromas, but were especially useful in those poromas located on the trunk and non-acral extremities, as we can see here, like our patients. They found white interlacing areas around vessels, even more common and useful in general poromas. Other structures, apart from milky red globules and poorly visualized vessels, they found yellow structureless area in 32% of general poromas. And if we remember the last of our lesion, the plaque located on the lower leg, we can see here this yellow structureless area, apart from these branched vessels with rounding endings and these interlacing white areas around vessels. So the occurrence of multiple poromas in the same patient is referred to as poromatosis, okay? But is this ecrine or apocrine poromatosis? Well, histopathologically, if you see findings associated with apocrine differentiation, like the connection of cords to pre-existing follicular infundibula, if you see large dots with the decapitation secretion, or mostly if you see these groups of mature sebocytes, these poromas are apocrine poromas. And it's very useful because cases of ecrine poromatosis are very rare in the literature and mostly occurred in patients, okay, treated with chemotherapy, as we can see in this slide. But cases of apocrine poromatosis are even less frequent. In fact, there are only 2 cases described in the literature, and neither of them were treated with chemotherapy. So, okay, nothing else. Congratulations to all of you who voted apocrine poromatosis. It's a different case. And well, I hope it's been very useful for all of you. Thank you for your attention.
So great cases, Pedro.
Great.
So if you present a case and I did not know the diagnosis, I would say poroma or collision tumor. So because you are a master of these.
I have to study other things.
I know, but the last 2 presentations were very educational. So thank you very much. There are no questions in the chat, but Rosario, do you have any comments to these poromas? So I miss you during the session in the beginning, because your screen was out of my my computer. So you should have time to add something to the cases.
No, I think that it was an interesting case. And I want to say thank you to Pedro and to my colleagues and people here in the organization told me that we are on time, that if it's possible to you can finish the session, Dr. Stoll.
I have to finish, I
Sorry.
guess. They say I have to finish. So, yeah.
Okay.
Thank you very much.
I think that it was amazing session, and thank you very much to all.
Yeah, so thank you and give the best also the thanks to the organizing and the computer specialists behind the scene for all the management. And yeah, and thank you for these beautiful cases we had the opportunity to see. So especially also your two cases, Rosario, with these perfect vessel types in melanotic melanoma and BCC. And as always, Pedro, and also the rare, very rare cases of Russia. So thank you for the interesting hour, and see you hopefully in person again, and also the audience, and bye-bye.
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 Hi everybody, Claudio Conforti here from the Dermatology Clinic of Trieste. As you can see here, I'm recording this lecture with the main square of Trieste, Piazza Unità d'Italia, in the background. And this is really a beautiful city in the north of Italy, and I hope to see you soon here. And today I'm going to discuss with you a new classification of cutaneous squamous cell carcinoma. And before starting, I would like to thank Professor Lallas and Professor Zalaudek for inviting me in this Rising Star session of the International Dermoscopy Society Congress. Let's start with general information regarding keratinocyte skin cancer. You know that keratinocyte skin cancer are a typical cancer of the aging population. The most common form of this tumor is actinic keratosis that can progress into squamous cell carcinoma. The problem is that keratinocyte skin cancer, the term keratinocyte skin cancer, stands as an umbrella for different stages within the progression of cutaneous squamous cell carcinoma. In fact, actinic keratosis can progress into squamous cell carcinoma, but for the same tumor, different terms can be used. For example, Bowen's disease versus in situ squamous cell carcinoma, or keratoacanthoma versus well-differentiated squamous cell carcinoma. This is the reason why today I'm going to show you for each tumor the clinical, dermoscopic, and histological features. Let's start with actinic keratosis that clinically can be classified into 3 different grades. Grade 1, in which the actinic keratosis are slight palpable, feels better than seen, and grade 3, the actinic keratosis is very thick and hyperkeratotic. In this case, the diagnosis is obvious. Dermoscopically, grade 1 actinic keratosis is composed by a red pseudonetwork with fine scales. The grade 2 of actinic keratosis probably is the most famous pattern of dermoscopy, the so-called strawberry pattern, because it is composed by a background erythema with hair follicles, white hair follicles, and grade 3 actinic keratosis composed by structureless white-yellow keratotic areas. And there is a correlation with the histopathology, because grade 1 actinic keratosis shows the presence of atypical keratinocytes located only in the lower third of the epidermis, while grade 3 actinic keratosis has the presence of atypical keratinocytes in the whole epidermis. For pigmented actinic keratosis, there is also a classification into 3 grades. Grade 1, composed of brown lines, erythema, and scales. Grade 2, composed of gray and brown lines together with these large follicular openings. And grade 3, that is really a difficult lesion when located on the face, because obviously it's not a beautiful lesion, but if you see white clots and a sharp demarcation, you can confidently diagnose a pigmented actinic keratosis. But now I have to introduce the concept of field of cancerization. Field of cancerization is the coexistence of clinical visible and genetically altered keratinocytes, and each single altered keratinocytes may proliferate and give rise to de novo actinic keratosis or de novo squamous cell carcinoma. This is the reason why therapy should always aim to treat the whole field of cancerization and not only the single actinic keratosis. And based on the field of cancerization, there is a new classification based on burden of disease. Single actinic keratosis defined as the presence of 5 lesions in a defined area. Multiple actinic keratosis when we have more than 6 lesions in a defined area, while field of cancerization is defined as the presence of more than 6 actinic keratosis with some damaged skin and signs of hyperkeratosis. immunosuppression any type if associated with immune zone suppressions. There are three pathways of actinic keratosis: the persistence, regression, or progression. But the question is how to understand which ones will progress into squamous cell carcinoma. We know that the presence of red radial lines or of glomerular vessels are signs of tumoral neoangiogenesis. So if you see, for example, a strawberry pattern actinic keratosis, and in the context of the strawberry pattern, the presence of glomerular vessels, it's better to biopsy, to do a punch biopsy of this area, because the risk of progression into squamous cell carcinoma is really high. But now let's move on Bowen's disease and cutaneous squamous cell carcinoma in situ. They are Bowen's disease and squamous cell carcinoma in situ are used as synonyms of the same tumor, as synonym of in situ form of squamous cell carcinoma. But the overlapping use of these terminologies can create a little bit of confusion in the classification and in the risk assessment of progression of these two kinds of tumors. So, this is the reason why our research group last year published an article entitled "Integrating the Concept of Field of Cancerization in the Classification and Risk Assessment of Cutaneous Squamous Cell Carcinoma," in which we propose a new classification and terminology of keratinocyte skin cancer based not only on dermoscopy, but combine dermoscopy with the clinical appearance of the tumor. In fact, you can see on your left side what for us is the classical Bowen's disease, a single tumor not surrounded by the other actinic keratosis, while on your right side you can see a classical intraepidermal carcinoma surrounded by actinic keratosis and other keratinocyte skin cancer. So the classical Bowen's disease is not associated with field changes, typically arises on some protected areas with a very low risk of progression, while classical intraepidermal carcinoma is associated with field changes, arises on sun-exposed areas, and has a certain risk of progression. Dermoscopically, they both show the presence of clustered coiled glomerular vessels and yellow scales. So to correctly diagnose this tumor, yes, it's obviously important to use dermoscopy, but remember to analyze also the surrounding skin of the tumor. Again, other two examples: figure A, a single patch located on the leg of a gentleman with glomerular vessel in dermoscopy. This is the real Bowen's disease because this tumor is not surrounded by other actinic keratosis, while in figure C you can see a tumor surrounded by other actinic keratosis with glomerular vessels in dermoscopy, and this is the squamous cell carcinoma in situ. While for cutaneous squamous cell carcinoma can be classified in well, moderate, or poor differentiated forms, or more important, in low risk and high risk tumors. Just to remind you that tumor bigger than 2 centimeters with ill-defined margins or with a poor differentiated grade of differentiation are associated with a high risk of progression, but obviously also the clinical appearance of this tumor is important because low-risk squamous cell carcinoma is typical a well-differentiated subtype, while high-risk tumor is located on periepiphyseal zones with a clinical diameter more than 2 centimeters. And now the question is how to correctly differentiate the well-differentiated cutaneous squamous cell carcinoma from keratoconthoma. This is how to understand which came first, the chicken or the egg. But the same concept that we saw for Bowen's disease and in situ squamous cell carcinoma, we can apply the same concept for keratoconthoma and well differentiated squamous cell carcinoma. As you can see on your left side, the classical keratoconthoma is a nodule not associated with actinic keratosis, while well differentiated squamous cell carcinoma is a nodule located also on sun-exposed areas, but surrounded by field of cancerization, by actinic keratosis and hyperkeratotic lesions. So just to summarize, keratoconthoma is not associated with feed changes as a self-limiting curse with no metastatic potential, while classical well-differentiated squamous cell carcinoma is associated with feed changes with a progressive course and a low metastatic potential. And regarding HPV, we studied the presence of HPV, the human papillomavirus, in samples of keratoconthoma, well-differentiated squamous cell carcinoma, and Bowen's disease. We published this study on British Journal of Dermatology, and we found that nearly 95% of keratocanthomas have the presence of HPV. So probably human papillomavirus can be a trigger of this tumor. And also the clinical presentation of squamous cell carcinoma is associated with a different course, because the well-differentiated subtype has a esophytic growth, while poorly differentiated has an infiltrative growth. And the keratoconthoma dermoscopically shows the presence of radial, linear, or curved vessels with a central mass of keratin with hemorrhages, while well-differentiated squamous cell carcinoma has not the presence of radial lines at the periphery, but the most important clue is the presence of white circles. So if you see a nodule with white circles, you should remember that white circles are really associated with squamous cell carcinoma well-differentiated subtype. While for poorly differentiated squamous cell carcinoma, there aren't specific criteria, dermoscopic criteria, but polymorphic vessels can be found with or without yellow to white hue and absence of signs of keratin. So in conclusion, to correctly name keratinocyte skin cancer, you have to evaluate obviously the tumor, but also the surrounding skin. So you have two possibilities: the presence of field of changes or the absence of field of cancerization. In case of field of absence of field of cancerization, you can have flat or nodule plaque lesions. A flat lesion not associated with field changes with glomerular vessels in dermoscopy can be confidently diagnosed as Bowen's disease, while nodule plaque with radial lines should be named as keratoconthoma. While if we analyze a flat lesion on a field of cancerization with strawberry pattern, this is a typical actinic keratosis, while if we see glomerular vessels, the diagnosis is not of Bowen's disease, but of squamous cell carcinoma in situ, because of the presence of this tumor in the context of field of cancerization. While if we see a nodule plaque located in the context of field of cancerization with white circles, as I told you before, white circles are associated with squamous cell carcinoma. So thank you for your attention. I hope really to see you soon, and why not in Trieste. Bye.
Excellent lecture. I will say this is a lecture as a real rising star. Do you agree, Emilios?
Absolutely, a real rising star with innovative concepts, because that's the the important thing.
The real rising star. Do you agree, Emilios?
We just hear ourselves twice, so maybe you should mute the Congress platform. So, Claudio, it was really great. The concept is very nice and makes sense in my view. But though I have a couple of instinctive questions that come in my mind. The first one, if you allow me to begin, panelists. So the first one is the following. So I understand, and it makes sense that Bowen's disease develops in non-sun damaged skin, true. And also keratoacanthoma in non-sun damaged skin, true. In contrast, actinic keratosis and classic squamous cell carcinoma on sun damaged skin. Okay, so then this suggests, obviously, as you pointed out, a different etiology. So in the second category, we have the predominant role of ultraviolet sun radiation, while in the first category, not so much. And for keratoacanthoma, you said it's probably HPV, and you showed the study that you found HPV. But for Bowen's disease, then what? What could be an alternative hypothesis, since you showed that there was not HPV in Bowen's? Do you have any idea?
Yes. Yes, this is really a good question, Emilios. Thank you. When I started to study the HPV rate in Bowen's disease and in situ squamous cell carcinoma, my hypothesis was to find the HPV in Bowen's disease. But our research, as I told you in my lecture, unfortunately, we did not find the HPV. Currently, we don't know what is another etiology of Bowen's disease. But probably we need new tools for detection of HPV, because I cannot exclude the presence, the role of HPV in Bowen's disease. We use a routine test, the PCR, to detect the HPV in Bowen's disease, and we published this pilot study only on 30 cases. So probably we have to extend the number of samples. For the moment, I don't know. I'm sure that keratoacanthoma is like a wart, because clinically they are really similar, and also the natural history of keratoacanthoma remember the wart. For Bowen's disease, probably not only UV rays play a role, but for the moment I'm not confident to say you that HPV can be excluded at 100%.
Yeah. Thank you. And I guess that this distinction in these two subtypes has also practical implications in management, because if this is true, then in the category A, we just have to treat the solitary tumor with some way, and then that's all. While in category B, we have to treat the tumor and also treat the field necessarily. I guess that this is
this is the message. We have to find in the next months we will start a new study just to find the HPV in situ squamous cell carcinoma, because we have to exclude that in situ squamous cell carcinoma have HPV in its pathogenesis. But the goal of this classification is to identify a lesion that can be treated, for example, with cryotherapy, Bowen's disease, with a local therapy, while for in situ squamous cell carcinoma, as I told in my lecture, is associated with the other actinic keratosis with field changes. So we have to treat the whole field of cancerization, because if we treat only the in situ squamous cell carcinoma, the patients in 3 months comes back in the clinic for a new lesion, and we in Trieste every day visit a lot of patients with a severe form of field of cancerization with the new growing lesions with the different keratinocyte skin cancer. So the message is to treat the whole field of cancerization.
It's great that you will start this study, but before this, you deserve a few summer vacations because you did so many studies in the last years that honestly you deserve. I can speak to your boss if you like.
Emilio, so you have to speak with my chief.
Okay.
Yes.
Other questions from any other of the panelists?
No, I mean, I wanted just also to add something that is in my heart since a long time and which should be another study. But I mean, Claudio is already at the limits of starting studies. So I need to individualize maybe someone else. But since there are many researchers and friends and young researchers, I mean, what we do in everyday practice, right? We excise a squamous cell carcinoma, but we know squamous cell carcinoma in 80% is associated with actinic keratosis. But we do surgery and then we usually do not anything else. Patient is sent home without treatment. So what should become state of art, in my view, in the future is that we excise squamous cell carcinoma, but then we follow a repetitive field treatment because we also know that these patients are prone to develop multiple tumors over time. And this is something that I think for practical practice might be relevant. There are first data showing indeed that field treatment reduces the recurrence of new tumors. So this is something that I like to add from my side. And of course, that Claudio is a superstar is clearly.
That's clear. That's clear. Okay, let's move to the next superstar, and we come back in a few minutes.
Dear colleagues, good afternoon from Thessaloniki, Greece. First of all, I would like to say that it's a great honor for me to be part of this Rising Star lecture, and I'm very thankful to the organizing committee for this great opportunity. But most of all, I would like to say how grateful I am to the two persons who actually made me deeply love dermatology and the special dermoscopy, and are two mentors to me. I'm referring to Zoya Pala and Emilio Lalas, and I feel very happy to be part of their team and work with them daily. And as you may not know me, please let me introduce myself. My name is Christa Papageorgiou, and I am a dermatology trainee, and since last year a PhD candidate here in Thessaloniki, Greece. My special field of interest is skin cancer and dermoscopy as well. So, I have selected to present you three of our studies, all of which were originated from common mistakes that we did in our everyday clinical practice. So, I believe that they are of high clinical significance and may help to improve our diagnostic accuracy in tricky lesions and guide our treatment decisions in our everyday practice. So, let's start with study number 1. These lesions are typical examples of Bowen's disease, typified by dotted vessels, glomerular vessels, and white or yellow scales. However, we observed lesions like these, which are quite similar with the previous ones, dotted vessels, glomerular vessels, and white scales. So, although we excised these lesions as Bowen's disease, the histologic report came back to us as superficial BCCs. So we decided to perform this study in which lesions of histologically diagnosed superficial BCCs and Bowen's disease were included. The study consisted of 2 steps. In the first step, we analyzed the lesions for the presence of predefined dermoscopic criteria according to the literature. Due to lack of time, I will not show these results, but more or less were consistent with what we already know. But I will focus on the results of the multivariate analysis, according to which dotted and glomerular vessels proved to be predictors of Bowen's disease, while the presence of pigmented structures such as leaf-like areas, spokewheel areas, and concentric structures, as well as arborizing vessels, were predictors of superficial BCCs. At the second step, three investigators with experience in dermoscopy were asked to classify the tumors as superficial BCC or Bowen's disease based only on the dermatoscopic image without analyzing the dermatoscopic criteria at all. And although most of the lesions were correctly classified, there were still some cases, mainly of superficial BCCs, that were misclassified as Bowen's disease. The analysis showed that the risk factors for this misclassification were the location on lower extremities and the presence of dotted vessels, while the presence of pigmentation was a protective factor. And indeed, when analyzed, most of the misclassified superficial BCCs were located on the lower extremities and displayed dotted vessels. So, at the final step, we further analyzed the dermoscopic morphology of lesions located only on the lower extremities, and we saw that dotted vessels and glomerular vessels, which were much more frequent in superficial BCCs located on the lower extremities as compared to other locations. Interestingly, we saw that white shiny blotches and strands were not only much more frequently, but were exclusively found in the superficial BCCs on the lower extremities as compared to other sites. And after repeating the multivariate analysis, but this time only for lesions located on the lower extremities, we found them, along with superficial fine telangiectasias, as positive predictors of superficial BCCs, while dotted and glomerular vessels remain the positive predictors for Bowen's disease diagnosis. And let's see a few examples of these superficial BCCs on the lower extremities, typified by the white, shiny blotches and strands. And again here, examples of superficial BCCs on the lower extremities, typified by dotted and glomerular vessels and these white, shiny blotches and strands. So, as a take-home message, we should keep in mind that superficial BCCs on lower extremities may also display dotted and glomerular vessels, and therefore the differential diagnosis between Bowen's disease and squamous and superficial BCC should not be exclusively based on the vascular structures. Of course, dotted and glomerular vessels remain the hallmark of Bowen's disease. However, we should keep in mind that superficial BCCs on lower extremities may also display dotted and glomerular vessels. In such cases, the presence of white shiny blotches and strands may be an additional clue that could help for the discrimination between these two tumors, as they are suggestive of superficial BCC. The second clinical dilemma we came across was the differential diagnosis between an irritated seborrheic keratosis and the squamous cell carcinoma. We know that irritated SEBKs do not display the well-known SEBK criteria. Instead, they may display characteristics such as scales, crusts, erosions, making their diagnosis very difficult. Moreover, as a keratinizing tumor, an irritated seborrheic keratosis may share common characteristics with other keratinizing tumors, such as squamous cell carcinoma. For example, in these lesions, which are quite similar, both of them are non-pigmented, slightly elevated, but they are similar not only clinically but also dermoscopically. Both of them display multiple vessels erosions, and the scales. However, one of them is an irritated seborrheic keratosis and the other is a squamous cell carcinoma. So we decided to perform this study in order to evaluate the dermatoscopic features of these two tumors and find potent predictors for their differential diagnosis. Our analysis confirmed that the vast majority of irritated sepcase do not display the classic sepcase criteria and that irritated sepcase and squamous cell carcinomas have many similarities from a dermoscopic point of view. However, there are a few differences in the frequencies between the two tumors regarding vessel morphology, vessel arrangement, and dermatoscopic features that I will not analyze again due to lack of time, and I will focus directly on the analysis, on the multivariate analysis, according to which dotted vessels, white structureless areas, and white circles surrounding follicles proved to be positive predictors for squamous cell carcinoma. In contrast, hairpin vessels represented a predictor of an irritated sepcase. We made also a subgroup analysis in which we found that diffuse irregular and peripheral vessel arrangement were predictors of squamous cell carcinoma. In contrast, a diffuse regular vessel arrangement was a predictor of an irritated seborrheic keratosis. In addition, we found that the presence of central scales was a predictor of squamous cell carcinoma, probably corresponding to the keratoacanthoma type of SCC. And last but not least, although we expect to see white perivascular halos in keratinizing tumors, we saw that quantity also matters. Specifically, we show that white halo surrounding vessels in more than 10% of the lesion as compared to less than 10% of the lesion proved to be a predictor for an irritated sepcase. So when we see multiple white halos, this favors the diagnosis of an irritated sepcase. So, for the discrimination between an irritated sepcase and squamous cell carcinoma, when we see dotted vessels, white structureless areas, white circles, and central scales, then we should think of an SCC. In contrast, when we see hairpin vessels in a diffuse regular arrangement, a diffuse scale arrangement, and multiple white halos, then we should think of an irritated seborrheic keratosis. And this is the last study I will present. This is actually a very fresh study that has been recently published in JAD, the aim of which was to investigate the criteria that could suggest an early invasion from an actinic keratosis to a squamous cell carcinoma. And let's see an example. In this clinical scenario, this lesion is an actinic keratosis, and due to dermoscopy, not only clinically but also due to dermoscopy, we are able to recognize it and discriminate it easily from this advanced squamous cell carcinoma. In these cases, however, which are again squamous cell carcinomas, but at the very initial stage of dermal invasion, the lesions are still clinically flat, and their discrimination from an actinic keratosis is very, very difficult. So, we prospectively analyzed 45 actinic keratosis and 50 early squamous cell carcinomas. According to this table, actinic keratosis lacked dermatoscopic vessels or displayed monomorphous vessels, while early squamous cell carcinoma displayed mainly polymorphous vessels. The most common dermatoscopic criteria of actinic keratosis and early squamous cell carcinomas were more or less consistent with well-known criteria that have been already described in the literature. For example, actinic keratosis more commonly displayed scales, background erythema, erosions, and white and white follicles, while early SCCs more commonly exhibited scales, white structureless areas, and ulceration or bleeding. Again, focusing on the results of the multivariate analysis, we found three main positive predictors of squamous cell carcinoma. First, dotted or glomerular vessels. Second, hairpin vessels. And third, white structureless areas. While background erythema represented an actinic keratosis predictor. Our univariate analysis also suggested three additional predictors for squamous cell carcinoma, namely the ulceration and bleeding, white halo surrounding vessels, and white circles surrounding follicles. Correspondingly, rosettes, scales, and monomorphous vessels were proved to be predictors for actinic keratosis. And let's see a few examples. These lesions are flat or slightly elevated. The left one is a lesion on the dorsum of the hand, and probably most of us would think that this is an actinic keratosis and would decide to do cry or a topical treatment. However, if we put our dermatoscope on the lesion, we will see not only scales and erosions, but also multiple peripheral hairpin vessels surrounded by white halos. On the right lesion, flat lesion, again, if we put our dermatoscope, we will see white structureless areas, white circles, and polymorphous vessels consisting mainly of dotted or glomerular vessels and hairpin vessels surrounded by white halos. All of them were excised and they were squamous cell carcinomas on the ground of an actinic keratosis. Again here, flat lesions, palpable lesions on the scalp, and the flat lesion, completely flat lesion on the forehead. In the first one, we see scales and white structureless areas, while in the right one, we see multiple white circles. Again, reasons for excision. Both of them were early squamous cell carcinomas. And the last example, the first lesion is a clinically flat lesion, typical for AK, not only clinically, but also dermoscopically. The lesion displays background erythema, erosions, and scales, while this lesion, although it looks a lot like a flat AK, if we put our dermatoscope, we see not only an ulceration and bleeding, but also multiple dotted vessels that should prompt an excision to rule out squamous cell carcinoma. So, as a take-home message, in clinically flat or slightly elevated lesions in which the differential diagnosis is between actinic keratosis and early SCC, when we see dotted or glomerular vessels, hairpin vessels, white structureless areas or ulceration and bleeding, white perivascular halos, and white circles, we should think of an early SCC, so we should think of an excisional biopsy and not a topical treatment. So, thank you very much for your attention and hope to see you soon.
You are live now?
So, wonderful lectures, wonderful studies. it's really interesting to see that our rising stars are focusing very much on keratinocyte skin cancer. And I think really the study on differential diagnosis, superficial basal cell or basal cell carcinoma versus Bowen's disease on the lower leg adds a really practical, relevant information, because there very often we are not sure, is this BCC, is this keratinocyte skin cancer? So very great results, compliments from my side.
Thank you very much.
Raimons.
Yes, I also listened very attentively, and also my compliments to Rising Star. So, but from practical, maybe yes, these take-home messages, but three main differences to summarize your studies. Where are these differences?
The differences between what?
Between superficial basal cell and Bowen on the extremities.
That the presence of dotted or glomerular vessels may also be seen in superficial BCCs and not only in Bowen's disease, because we cannot be sure that a flat lesion on the limbs that display dotted or glomerular vessels is for sure Bowen's disease. We should keep in mind that it may be also superficial BCC. And this maybe has a point due to the treatment we will follow, because in a Bowen's disease maybe we will prefer to do a biopsy and an excision and not topical treatment as in superficial BCC.
Thank you, brilliant.
Lower legs are conflicting in several tumors, because the morphology of several tumors changes a little bit on the lower legs, possibly because of the stasis of the blood stasis. And also another point is that these white shiny blotches and strands, which is a quite recently described feature for BCC, appears to be particularly frequent in this anatomic location on lower limbs, lower legs.
But Emilio and Crisula, they were just superficial basal cell carcinomas, or did you include also invasive ones or infiltrating ones?
No, superficial.
Only superficial.
Only superficial, because it's interesting that we see these features so frequent on the lower leg, which in melanoma is considered the sign of invasion. So it's quite interesting. Anyhow.
Yeah, the shiny structures, you mean?
Mm-hmm.
Yeah. And the other message is that don't trust vessels on the legs. That's also a good lesson.
Yeah.
Yes. A rising star. She explained it very, very clearly and slowly, and we may. In Brazil, we have to put our dermatoscope and to check several lesions. And I always say to the residents to pay attention to the clues and do not use destructive method or like cryo or emission mode if they don't know the diagnosis. So if you take in mind this take-home message, you will proceed incisional biopsy, even use topical treatment. So the rising star is an excellent rising star.
Thank you, Beth. This is a very nice comment, a very nice message that cryo and imiquimod are not solutions to our diagnostic uncertainty. Cryo and imiquimod are treatments with specific indications. Okay, thank you, Chrisa, very much. I think we should proceed.
Emilios, I think that I deserve also summer vacation. I have to stay.
We will discuss about it. We will discuss about it later.
Yes, now Prof. Zalaude can talk with Emilios and vice versa. Okay?
Don't worry, don't worry. You will have it.
So our next rising star is in fact already a shining star. It's Kelly Nelson from the US, and we will be happy to hear her lecture and come back in a few minutes.
Hi, my name is Dr. Kelly Nelson. I'm an associate professor of dermatology at MD Anderson Cancer Center. And it's my distinct privilege to be able to spend some time with you talking about one of my passions, a new paradigm for dermoscopy education. So in 2013, I moved from Duke University to MD Anderson in Houston, Texas. I met with our melanoma moonshot team. Our moonshots at MD Anderson are internal funding opportunities to fund high-risk, high-reward research. And we started talking about how to structure an early melanoma detection initiative for Texas, which is not small, geographically speaking. So I reached out to the 12 academic dermatology residency programs and talked about developing one dermoscopy curriculum for all the residents of these programs. And it was really to develop a proof of concept for being able to teach primary care doctors dermoscopy. Along the way, I partnered with Dr. Janice Wilson and Dr. Stephanie Savory, outstanding dermatologists in Texas, to develop our curriculum. We taught using clinical comparators, things that look similar clinically, but where dermoscopy can help you tell the difference between the two. And we've done this curriculum for the past 4 years. Every year we've tried to do things a little bit better. Now, in year 3, we took our monthly lectures, we compressed them into one 3-hour mega lecture. And I gave that mega lecture to 18 residency programs. And every time I tried to make it a little bit better. Even pre-pandemic, we had already laid the groundwork to transition from live education to interactive web-based modules. Along the way, we developed and validated our instrument to measure gains in confidence and in dermoscopic image interpretation. And we showed that the bolus and practice model, doing that mega lecture up front and then having an opportunity to practice those skills during the academic year, led to greater gains in ability to diagnose dermoscopic images. So this is just a quick overview of our interactive curriculum. It's available through any web-based device. Residents can search for a specific phrase or fragment of a word, and then the curriculum, they can go to those specific areas in the curriculum where that word or phrase was mentioned. They can see the options, they can choose the one that they're thinking about, and then go to that specific part of the lecture. And this is something I use when I'm in clinic with my residents as a teaching tool. The other piece of interaction that we developed is where we ask them to apply their skills into determining which lesion is a melanoma with a paired set. Then on the next slide, I explain why the melanoma is the melanoma. And then the third opportunity for interaction is where we teach a specific dermoscopic feature. We then ask them to click on that feature within an image, and we give them feedback whether they got the answer right or not. And then I provide an annotated image where I perceive that structure to be and explain why. But we set out with all this with an end goal of teaching primary care doctors. I established a collaborative relationship with family medicine doctors in El Paso, Texas. In El Paso, if you're underinsured or uninsured, it's really hard to see a dermatologist. So for those PCPs, I have to teach them to diagnose and manage because there's nowhere to send their patients to if they have a concerning skin lesion, and that takes a lot more work. We developed our pilot intervention and our instruments, but I still felt like I could do a better job of teaching them. And so around this time, 3 really important things happened. Dr. Vinnie Sieverling, who's on faculty at Maine Health, and I started working on a grant application where I really started to explore the science behind medical image interpretation. Veronica Rodenberg at Sloan Kettering and I started meeting more regularly, talking about my world of education and her world of ISIC and image annotation to support artificial intelligence algorithm development, and how we could bridge those two worlds. And Ralph Brown and I started meeting regularly to really brainstorm on how to tackle some of these really big challenges. And as I worked with all these really super intelligent and passionate and fun colleagues, I realized that with education, we tend to put together our lectures to be 45 or 60 minutes. And it takes a lot of work to develop those. So once we make them, we don't tend to change them. And we have one way of teaching, but our learners have many ways of learning. And so what ends up happening is it's sort of a one-size-fits-all approach that may or may not fit the needs of our learners, those who we're really trying to teach. And on the AI image annotation side, in a world of puppies and rainbows, you'd have hordes of dermoscopy nerds just waiting to annotate all the images for algorithm development. But the reality is that that's very hard to get us to do. There are gamified apps that are available to try to get novices to annotate images. And so the hope is that you crowdsource the truth in there, but what you're really trading is quality over quantity. So the crowd may get it wrong, and then your algorithm is being developed based on information that may or may not be correct. So how do we bridge these two worlds? So on the education side, thinking about how I wanted to have a new paradigm to teaching dermoscopy, the first concept is microeducation, taking that hour-long lecture and breaking it into several 5 to 6 minute lectures, so that even if you're waiting in the car to pick up your kids from school, you can get through maybe one module, but those modules add up over time. In this world of distance learning that we're in because of the pandemic, developing something from the ground up that can be deployed for smartphones is really important and prudent. On the flip side, for the annotation of images as to whether they have a specific dermoscopic appearance or dermoscopic feature or not, then wouldn't it be nice to set those up within the same vehicle so that people are going to one place to learn and to annotate the images both? But how do we link the two? So there are two concepts that are combined: perceptive and adaptive learning. Perceptive learning is when you teach someone a visual recognition skill, and then you ask them to perform that skill, and you tell them whether they're right or not. Adaptive learning is you measure the time to response in that question. If someone is fluent, they answer almost instantaneously. If someone is still learning and they're still having to think through the specific rules to that task, they may get the answer right, but it'll take them longer. And so you can use that time to response as a gauge for fluency. So we can look at the answers and the time to response using the perceptive and adaptive evaluation to gauge whether novices, whether they be medical students or just Joe Schmo off the street, whether they get it after reviewing our 3 training slides. If they get it, then great, we're done. But if they don't get it, if everyone gets it wrong, then you go back and you change your training. And you keep doing that until you get it right, and they get it right fairly quickly. Then once you're happy with your training slides and you finalize them, then you can use the perceptive and adaptive performance as a quality gateway. So only the people who perform with a certain degree of fluency are allowed to progress into image annotation for AI machine learning purposes. So now instead of getting just quantity of annotations, you have a certain control over quality as well. And for those who don't pass that bar at first pass, you give them more opportunities to practice and learn. So that also, this approach also gives us a third opportunity. We can use the novice annotations of these images from the ISIC archive to triage which ones are easy and which ones are hard. The easy ones are when the novices agree with each other and they're right. And we can use those easy pictures to then feed back into our educational repository of images for more training. But we also can identify the ones that are hard for novices, and we can really focus our expert annotation to the hard images where we really need their insight. But we're also starting to set up a human AI feedback loop for education, because we as humans can learn from AI's assessment of images. We can glean clues for diagnosis that may not be initially perceptive to us and how we look at images and think about diagnosis. But we can also identify ways to measure AI performance based on some of these human parameters that we're measuring. So key points, there's certainly a lot of work ahead in this space, but partnerships are so important, not only for those who we aim to teach, but also with colleagues, because there's way too much work to do alone, and it's so much more fun if we do it together. Everyone likes to win, and so setting up any educational endeavor so that there are easy wins up front. Also thinking about what are the most important things that we can teach so we have the biggest bang for our buck with our educational time with our primary care colleagues. Whatever we make, it has to be easy to use, it has to be easy to share, and it has to be sustainable, not only for our learners, but also for us, the teachers. It takes a lot of time, a lot of blood, sweat, and tears to put together these educational interventions. And if we don't get paid for it, if we don't have any way to pay for those to help us put it together, because there's no funding, because there aren't any grants, then it's not sustainable. And so thinking creatively about how to support these educational interventions is really essential to the longitudinal sustainability of them. To support practice change for our primary care colleagues, we have to be available to them when they have questions. We also have to help them make it easy to do the right thing. And so that may mean helping them set up a particular block of appointments of every other week where they see their skin patients, so they don't have to deal with that in the midst of a busy clinic. That's something where it makes it easy for them to do the right thing in the care of their patients. It takes an enormous team to support the thought process behind the slides that I've shared with you. The MD Anderson moonshot, the melanoma moonshot, has funded my effort for the past 4 years to do these educational intervention endeavors. And I've made a lot of friends along the way. And so I want to thank everyone who's on this slide and anyone who I inadvertently did not mention specifically for your support in my career development and in helping me reach this educational training gap. Thank you so much. Reach this educational training gap. Thank you so much.
So,
awesome.
Kelly, wonderful lecture. I think it's really very rare that someone is working on education, and I think this is you highlighted several points that are essential. And I also liked your way that you say we can learn from IE by taking out what they realized, what maybe was always in front of us, but we were not seeing it. So, and I think Harald Kittler did also recently reported that actinic keratosis were better in IE because they were looking at the skin around and not at the lesion. So very nice.
Thank you.
Kelly, really an awesome effort what you did, and especially in this era in which teaching is and will be performed very much online. Let me tell you that we plan to use these efforts that you did.
Josep, qué grande.
Rosario Peralta closed the microphone.
Oh, okay. So we plan to incorporate all this effort because, as you know, for the society, education is a primary goal, but this is not for the moment. My question to you would be, that came instinctively by watching carefully your points, was the following. Concerning the quality of annotations, are we sure that the quality of annotations depends exclusively on the level of training, since it has been shown several times that equally trained people, even experts, annotate in a completely different way the same lesion?
That's a very, very good point. And I think that within the framework of dermoscopy image annotations, we are not going to start with the hard things as we build our education. So we're going to start with the things where there is agreement, especially among dermoscopy experts, and then slowly work our way to the hard stuff. So I think to be determined how we address that, but we're going to start with the easy things first and learn from there and keep going.
Yeah. Absolutely. The other panelists, any comment, any question, Kelly?
Beth, how you do teaching at your clinic?
Microphone.
With your microphone.
Sorry. I was dermatology clinical preceptor, and my residents need a teacher of dermatoscopy or dermoscopy. So many years ago, I came study, and we have now ambulatory or outpatient ambulatory, and we train dermoscopy and melanoma. And I love to teach residents. We share knowledge, and we can go to Congress, and we can produce knowledge. And I came to Latin American Congress of Dermatoscopy with 4 kilos of posters, and I went slow alone, and I went to Congress with residents too, and we made friends all over the world. So we can train. If I was watching her presentation, and I was thinking about that. We have a small ambulatory. Our service is small, but we can make a great knowledge, and we can learn with the residents too. So if you are in a great hospital or in a great service, I'm not in Italy or in Greece. I work in a small city, but we teach with love, and I love to teach and learn with the residents.
Thank you, Beth, very much. Although we are running a little bit out of time, I want to ask another thing because it just crossed my mind. I don't know if you agree. Instinctively, just tell me. I feel that although we are moving in the digital era, although we need to provide online educational tools for teaching, the role of written text, which should not be completely abandoned, because I continuously receive requests today, not 10 years ago, from many young people that I speak with for written text. So I think that there are people that prefer this way of learning, and I mean, we should not stop providing also this way of education. Do you agree?
Yeah.
Full agreement. Okay.
100.
Great. Okay. So, should we move? Thank you, Kelly, very much. Extraordinary. Should we move? Yes, to the last rising star. And we hear the lecture and we are back again in 10 minutes approximately.
Hello, everyone. It is a real honor to be here today. My name is Ana Flavia, and I would like to thank the organizers and especially Professor Pascoal for the invitation. I am a dermatologist from São Paulo, Brazil. In Brazil, to be a dermatologist, I studied 6 years of medical school, then 2 years of general medicine, and after this, I studied 3 more years of dermatology at ABC University in Santo André. When I was in the dermatology residence, I was impressed with dermoscopy. All the colors, the highlight of so many structures invisible to the naked eyes, and the possibility to improve the diagnosis and recognize skin cancer with precision, it was and still is really exciting. During the residence and after it, as a dermatologist, I had a lot of questions about dermoscopy, and it was not easy. I had only one teacher that understood dermoscopy and explained it to me and to my group. Otherwise, we had to learn from books, through congresses, and especially with patients. With this, I noticed that I really needed to understand dermoscopy in depth. So to reach my goal, as soon as I became a dermatologist, I looked for more knowledge. I continue attending at the skin cancer outpatient at ABC University under the coordination of Professor Pascoal as a volunteer with dermatology residents, where I still am now. And I became a fellow in confocal and dermoscopy at AC Camargo Cancer Center. AC Camargo is a reference in cancer treatment in Brazil. It has existed since 1953, and it has been setting up the largest tumor bank in Latin America, serving approximately 20,000 new patients each year. Always ahead in technology and innovations, the AC Camargo achieves a cure rate of approximately 75% for children and 70% for adults, and also is a reference in improvement and specialized medical education. In 2017, I spent 2 months in the US in Memorial Sloan Kettering Cancer Center under the supervision of Dr. Mark Hope. This was very important since it was my first experience abroad. And it was an honor to work with Dr. Mark Hope and to learn with him and his team. The whole experience was unique and very different from my experience in Brazil because of the technology involved and how the team worked together, the nurses, the researchers, and the doctors. This enabled me to expand my knowledge, and so I returned to Brazil full of new ideas to enrich my practice and teaching skills. I started my master's degree project. I became an official member of the skin cancer team at AC Camargo, and I continue working at ABC University as a volunteer teacher assistant. During this time, I started teaching at congresses. It was a challenge, but dermoscopy always gave me new insights about how to diagnose. Studying about dermoscopy and working with it is always exciting and challenging. While teaching at congresses and teaching new dermatologists, I try to transmit this feeling because I know that in the beginning it is not easy. But when I think that we can improve the quality of our patient care, it becomes a huge asset. Currently, doing research in Brazil has been challenging, but being at university and AC Camargo, both research centers, I can put in practice all my knowledge. Research gives us a lot of work. And at the same time, I need to work, I need to make money, I need to be with my family. And this sometimes can be exhausting. But it is interesting because usually when this happens, at the same time, I receive an invitation to teach in a congress, and then I'm full of energy again. Because again, the possibility of improving patient care, spreading knowledge about dermoscopy, and trying to get dermatologists involved is really important to me. In 2019, I started my own private clinic, and dermoscopy is always present in my daily practice. I receive patients from other dermatologists seeking for a more precise evaluation, and I have been successful in reducing unnecessary surgeries. Of course, patients are also happy about it. I also receive patients looking for dermoscopy. They say that they feel safer when the dermatologist uses this device. With this, dermoscopy has been with me since I got involved with dermatology. I think that I still have a lot to learn about dermoscopy because with each patient, there is always something different or something new to learn. I'm very happy and grateful about the opportunity to teach other dermatologists. And I think as long as more dermatologists study and get involved with dermoscopy, more we can learn about it and improve patient care. I hope that all of you are enjoying this wonderful Congress. I am really grateful in sharing my story with all of you. And if you have any questions or would like to talk about dermoscopy, please contact me. I hope that you have enjoyed it. Thanks for your attention.
Great. Thank you, Anna, very much for this inspiring story, which highlighted very well the importance of fellowships, the importance of exchange of personnel so that you get in contact with other institutions in other countries and you get inspired by important people there, and then being able to apply what you learned when you go back. So which was the biggest change, Anna, when you moved from Brazil to the US and then back again?
Yes, so with the section theme, I thought I should talk about something different, talk about starting a career. So to me, when I was in United States, I was there about 2 months. It was very different, and it was like I get highlights about all my thoughts about all dermoscopy, and this was very grateful for me. I really changed my view about dermoscopy and my view about the patients, and as Kelly said before, about teaching, because I still work with residents, and after I went to United States, I could teach it from another kind of view, like a view about colors, about that technology, about how important is dermoscopy. And this is, like we said, this is sometimes difficult because we don't have something like a support to teaching other residents. And here in Brazil, we don't have a number about how many dermatologists have training about dermoscopy. So this is another challenge for us. And of course, we are happy because every year we have a lot of dermoscopy courses, and every year we have more dermatologists involved with dermoscopy. But I think we have so much to learn, and it was very good to go to United States. So it was this. And another thing that changed my view, it was the last Congress in Thessaloniki. That
Really?
Perfect to me. So thank you for being here with all of you, and congratulations.
Thank you, Anna.
No, very nice. And I think it's really something that we should promote, that people are moving to other centers. It's so enriching, the knowledge to come to a center where you see the differences and so on. And I think as directors of academic structures, we should definitely promote movement of our young fellows and colleagues. Do you agree, Chrysola? Not only vacations, but also maybe Claudio has a vision. He wants to go to Miami.
Yes.
Claudio,
if you want to come with me, Emilio's now. I hope that he will allow you to come. But for sure, I really think that the most important thing during our residency program is to exit from our comfort zone. Because when we work always in the same center, we work always in the same, we do the same things always in the same manner. And also exit, see other doctors, other centers can change, for example, can allow us to do the same thing in another way. And this is one of the most important thing. For example, in Italy, we in Trieste, we have more than 4 centers. So we visit with other doctors, and there are doctors really experts in dermoscopy, other in inflammoscopy, and so on. So this is the best way, in my view, to study, to learning, and then to teach.
That's a great
Excellent
point, Claudio. Bravo, great point. This is a really nice message. I fully agree that especially for young colleagues, they should receive that moving and having the experience of a different country, different way of approaching things, even if they work in a very well-established center, even if this is a priceless experience that enriches significantly the way you understand medicine in general, and in particular our field. So this is something very important, and we do have to find ways to support it and promote it even more. So that's a commitment. Okay.
Well,
any other comments or questions?
Just from my side, I wanted to thank the Rising Star lecturers for their great lectures. Yeah, thanks a lot. Beth.
Dr. Carls, I checked the chat, and there are 2 comments. To Kelly, Robert West, excellent work, Kelly. Love the transition of this to the PCP module. And Roberta Chufida, wonderful Congress and great speakers. Dr. Comfort continues to shine. Excellent presentation.
That's true. Claudio, continue to shine. I also find this message.
I paid Roberta for writing this message. Okay, you know.
Yes. Speaking, three beautiful ladies, and you received the compliment that you shine. You very proud.
It was a difficult thing to do, but I paid Roberta. Thank you, Roberta.
You see, Claudio is an Italian man.
Yes, I have to pay. To receive beautiful comments, I have to pay.
Yes.
A perfect Italian way.
Okay, guys.
Okay.
Thank you very much.
Thanks
it's
a
true
lot.
that the rising stars are the future. The rising stars are the reason why we are so optimistic. So thank you very much. And President, would you like to say the goodbye?
No, goodbye to now. The Congress is still ongoing, so I welcome you to the next lectures, and then I hope to see all again at the closing ceremony where we will give some data and updates. Okay, bye-bye.
Thank you.
Bye. Thank you. Bye.
Ciao.
Bye.
Bye-bye.
Because it is our duty to do our bit. Every time we care for a single person, we make the whole world better.
Dear everyone, it's my pleasure to take part in this amazing session about teledermatology, teledermoscopy, a truly hot topic that has become of interest after coronavirus shook up our lives. So thank you for this kind invitation. Ahora no va el, claro, le he puesto el láser y no va el ratón.
Perdón, me decías, no se mueve.
Ahora no se mueve la pantalla. A ver si es porque le he puesto el puntero láser. Sí, ya está, le quito el puntero láser, ya está, no te preocupes. Comienzo otra vez, disculpa, Ezequiel.
No hay problema, cuando quiera.
Dear everyone, it's my pleasure to take part in this amazing session about teledermatology, teledermoscopy, a truly hot topic that has become of interest after coronavirus shook up our lives. So thank you for this kind invitation. This is my conflict of interest as a partner in a teledermatology services company. Early diagnosis and treatment still remains the most determinant intervention to provide melanoma patients a longer survival. This early diagnosis relies on patients' awareness and willingness to seek care, and on the other hand, on accessibility to dermatology providers. However, the easier the access, the more the patients seek care, and thus the higher the chances to detect skin cancer in earlier stages. Over the last decades, healthcare services have approached this early diagnosis goal through some of these strategies. The first, a conventional letter referral for an in-person visit at the dermatology department, with some sort of fast-track referral pathways for patients with concerning lesions. Second, dermoscopy-based triage is carried out by the primary care provider. And finally, teledermoscopy between primary care providers and dermatologists. Our the first approach, this conventional face-to-face referral, has largely failed to accomplish the early diagnosis goal. Even in countries that have issued rules like the 2-week rule in the United Kingdom to make patients with concerning lesions be seen by a dermatologist in less than 2 weeks, this strategy has not succeeded. The high volume of non-relevant lesions referred to the hospital as a result of the low sensitivity of the decisions made by non-dermatologist physicians has hampered this goal. However, at that very time, 2004, dermoscopy was a racing diagnostic procedure that had been validated for the diagnosis of pigmented lesions. And so, dermoscopy was immediately seen as the tool that could increase this low sensitivity seen in family doctors' referrals. Simplified dermoscopy algorithms were developed and validated for that aim. Algorithms that could be taught to family physicians and then be applied to triage skin cancer in primary care settings. So, a nice approach, and actually a truly motivating strategy, both for family physicians but also for dermatologists. This study compared the performance of some of these simplified dermoscopy algorithms. The triage amalgamated dermoscopic algorithm, the TADA, the 3-point checklist, and the asymmetry color rule, all them showing apparently high performance, particularly in the case of the TADA, with such a remarkable sensitivity, as you see here on the screen. However, it seems that this diagnostic performance has not been enough to promote a more widespread use of dermoscopy for the routine practice in primary care settings. This other study compared the performance of family physicians assessing cutaneous lesions clinically or using the 3-point checklist for dermoscopy. But this study shows with no doubt is a remarkable improvement in sensitivity after using the checklist, and so that family doctors were much better when they used this simplified dermoscopic algorithm. However, this increased sensitivity still hides a 20% rate of false negative, what means a substantial risk for a cancer screening procedure. And also, this acceptable specificity also gives rise to roughly 1/3 of false positive results, and consequently to 1/3 of non-relevant lesions being referred for in-person visit, which still means a great deal of patience. But apart from this, there is an even more powerful reason that explains why training GPs in dermoscopy shouldn't be a single frontline strategy for that early diagnosis aim. And that is just epidemiology of cutaneous melanoma. Melanoma, except in Australia, the United States, and other few countries, is a low incident cancer type. Let's see. Spain, 47 million people, roughly 30,000 family physicians, and a yearly melanoma incidence about 9 to 10 per 100,000 inhabitants. So, how often, you wonder, is a family doctor expected to see a melanoma patient in real practice in Spain? Once a week? Once a month? In Spain, and according to these figures, every single family physician is expected to encounter a cutaneous melanoma every other 6 to 7 years. This is a low pickup rate that may contribute to explain, at least in part, why the training of non-dermatologists in dermoscopy should not be the only strategy if we aspire to an effective melanoma triage. Let's see, this grid represents a 10,000 population and one melanoma case, the black square in the left, as corresponds to the melanoma incidence in Spain. So, in terms of melanoma detection, this is slightly more or less than finding a needle in a haystack, a task that we believe teledermoscopy may carry out pretty well. And this is why teledermoscopy was, 10 years ago, our proposal to offer a readier and a timelier access for skin cancer patients, a goal that we could achieve very soon after the setup of the program. But in spite of these results, these achievements, teledermatology, dermoscopy still is a strategy under the spotlight and still not lacking opponents. Here we see the digital ecosystem we run at our dermatology department is based on a story-forward communication between the primary care provider and our department, initially for the skin cancer triage. But this first use of teledermatology skin cancer was widened, progressively widened, and we also started to use teledermatology for the access of patients with any kind of dermatology condition, as well as for digital follow-up of chronic dermatosis. For the pandemic, we just had to enable a direct connection between the patient and our digital center, and also between the hospital wards and our digital center to assess in patients but sparing avoidable hospital transits. Here I summarize the specific paths for referrals involving skin cancer and suspicious lesions. In this case, 100% of teleconsultations include clinical and dermoscopic pictures. These pictures, dermoscopic pictures, are taken by family physicians or operators of teledermatology operators in the primary care using these conventional digital photo cameras connected, adapted to this dermoscope using this magnetic ring, very, very useful, or even using their personal cell phones with this not less useful and very affordable magnetic ring adapted to the cell phone. I have no conflict of interest with any of these devices. So those patients consider the digital center to have highly suggestive or clear-cut malignant lesions suitable for excision and the local anesthesia are directly referred to our hospital operating rooms. More complex lesions or patients not suitable for surgery under local anesthesia are referred for in-person visits at our melanoma or non-melanoma skin cancer clinics. These are data from 2019, before the pandemic, and including both general dermatology and skin cancer referrals. Roughly 30,000 first visit requests that we worked out in less than 24 hours on average, and accessibility that today cannot be offered by conventional dermatology practices, and with 80% of them being managed with no need of hospital visits. Here we see the workloads related to the teledermoscopy program over the last 5 years, which represented roughly half the global requests in general dermatology. Please note the figures of skin cancer, or orange, with obviously with the collateral effect of managing this huge number of referrals of patients with non-relevant benign lesions in the left. However, the higher the number of seborrheic keratoses received and managed, the greater the rate of thin melanoma detected, a desirable effect from such a wide access offered through teledermatology and that we observed in this study. However, I have to say that in formal teledermatology program, this is not an issue at all, as an experienced and dedicated dermatologist working with an efficient telemedicine platform is able to handle this type of consultations in no more than 1 minute each. And this is the very advantage, what really explains the effectiveness and the efficiency of teledermoscopy in managing such high workloads and offering timely opinions from a dermatologist. From a diagnostic standpoint, teledermoscopy showed in this randomized clinical trial higher sensitivity and specificity with respect to teleconsultations based only on clinical pictures. And more importantly, and what makes the difference with the dermoscopic algorithms applied by non-dermatologists is this positive predictive value of 84%, which for screening purposes may be considered a pretty fair rate. So moving back to the different strategies, and as a summary, here we see the advantages and drawbacks of each of the strategies put into practice. High false positive rates and the high number of hospital visits of patients with benign lesions are the main drawbacks of the first two approaches, and the reason for the long waiting times they give rise to. Dermoscopy performed by family physicians also bears an additional weakness related to the long-term sustainability of doctors' training, particularly if we recall that figure of 1 melanoma every 6 or 7 years. About teledermoscopy, implementation, professional barriers against teledermatology, and picture quality are the main limitations or barriers to solve that we have to tackle when doing this strategy. About pictures quality, we train physicians and teledermatology operators using videos and short workshops. And I have to say that dermoscopic pictures, as they are taking use in the light and distances offered by the dermoscope, quality is excellent in more than 90% of the teleconsultation. That's the pictures quality in some real cases in which the dermoscopy even run more accurate assessment than in-person dermoscopy. Let's see, this patient had been seeking care for the lesion that was considered in up to 2 previous in-person visits as a seborrheic keratosis, and so treated with cryotherapy. This is the dermoscopic picture of this patient, picture taken at the primary care center and submitted to the digital to our department. A picture that is enough to see this pigmented network in the border, in the base of the lesions network that brought out seborrheic keratosis and led us to consider immediately diagnosis of malignant melanoma. I don't want to be rude with that, but I insist on these cases because I'm always asked about what if you make a mistake when doing teledermatology. However, nobody usually cares about mistakes that also happen, that we also commit in conventional in-person care, particularly when the dermoscopy is not used properly. This is a high-quality reassuring teledermoscopy picture, of a lesion submitted as a fast-growing concerning lesion on the soul, hematoma. The hematoma handled at our digital center in less than 1 minute. And here we see another excellent dermoscopic picture taken by the staff of our primary care center. So just examples of the type of pictures we deal with in the teledermoscopy-based skin cancer program. And moreover, if you can see these dermoscopies in these screens, the large screens in the digital area, and even sharing them with a colleague, the dermoscopy assessment, teledermoscopy assessment, may be even more satisfying than when looking at these lesions through the tiny lens of our dermoscope in face-to-face dermoscopy. And consequently, happier staff smiling. No mask was before the pandemic, but definitely offering and providing better outcomes. So, to conclude, in my view, combining the high specificity and performance of teledermoscopy and having family physicians engaged in dermoscopy would be, in my view, the ideal approach to be successful in our major goal of providing the access that may better contribute to the health outcomes of skin cancer patients. It's not a simple task, but worth attempting. And in the meanwhile, dermoscopy will not let you down. Thank you for your kind attention. I see you soon.
Hello everyone, this is John Pauli from Gothenburg, Sweden, and this will be a lecture on teledermoscopy, but also teledermatology in general, and what we've learned in times of pandemic. At least we have been doing a lot of research, so I hope we've learned a lot. As you can see here, in 2020, the numbers skyrocketed up, and even in 2021, we've seen a lot of new publications, over 100, and even more than we saw during the whole year in 2019. For teledermoscopy, same trends with a lot of more publications in 2020 during the pandemic, and even more coming this year. So excellent trends and things happening, going on within these fields. Before the pandemic, I think most of you, or many of you, were at least familiar with some of these logos, WhatsApp, FaceTime, Facebook Messenger, but we became accustomed to seeing new logos and learning more about Microsoft Teams, Skype, Zoom, even holding these conferences and congresses virtually, online, and being able to communicate with our colleagues and, of course, our patients. So, but at the beginning of the pandemic, things weren't really clear, and a lot of people were recommending, a lot of associations were recommending deferring surgery, deferring skin cancer visits. This could wait. And of course, the situation was a bit hopeless in the beginning. The British Association of Dermatologists, just to give you one example, we're considering deferring all surgical excisions of basal cell carcinomas for 3 to 6 months, even squamous cell carcinomas in situ, or small, well-differentiated squamous cell carcinomas, or melanoma in situ. But of course, deferring these forever was not an option. So eventually we had to start doing something. And the way to help our patients in the best possible way and triaging in a correct way was, of course, teledermatology. So just more numbers showing the impact, showing in England a decrease in the number of diagnosed melanomas here, same trends for keratinocyte cancers, but then slowly recuperating as we understood that we have to do something, and we incorporated methods to do this with teledermatology. Fortunately, in England at least, they saw no impact on pathological tumor staging among their cases, with the median thickness of BCCs, SCCs, and melanoma being non-significantly different before and during the pandemic, which was good, but this wasn't the case for all countries. Canada, again, showing the number of diagnoses of melanoma just dropping. This is the dark blue line. As the number of COVID cases increased, and then as they decreased again, we were able to see the patients, or they were in Canada at least, and the same numbers, same trends for keratinocyte carcinoma. So drastically underdiagnosed during the pandemic. Italy, 50% fewer melanomas diagnosed in 2020 in South Italy. This was a country that was hit really hard in the beginning of the pandemic, as you know. And 60% fewer melanomas in Northern Italy, and 30% less dermatological surgery. So really terrible numbers. And of course, this can affect prognosis in many cases. This was a report from another center in Italy showing that the number of advanced skin cancers increased from 8.3% of their cases to 19.3% of the cases. So this was a tragic trend seen there, at least. In the US, also some departments seeing that melanoma patients, the Breslow thickness of their invasive cases increased from 0.8 to 1.4. Not the case for every study out there, but some of these cases were, some of these publications were showing these numbers, which is unfortunate. And the numbers of T1, T2 stage tumors was decreasing from 80% of the cases to 64%, and of course, instead being diagnosed in later stages. Similar results from a smaller study in Spain, where only 48 cases were diagnosed in 2019, but even fewer, 18 cases diagnosed in 2020. And again, fewer melanoma in situ and more thick melanomas. So unfortunate numbers that we had to change. So teledermatology came around to save the situation, at least help. And this is the results of the survey from the IDS, in which they had 678 responders from 52 countries. And they looked at the numbers of non-melanoma skin cancers diagnosed even with teledermatology during the pandemic, seeing that most participants noticed, this is 84% were noticing a lower number than usual, and 37% actually saying almost 0 cases during the pandemic. In terms of melanomas diagnosed, even with teleconsultations, also the same type of numbers, and over 50% actually responding that they found almost 0 melanomas during the pandemic. So really tragic numbers, but they were asked to do more teleconsultations, and this was what perhaps changed that number to better percentages during the later part of the pandemic. They were increasing for most, doubling in many cases, and multiplying by even more in 40+% of the participants' departments. So this is great. Curiously, they were using unofficial teleconsultation systems, email, SMS, Messenger, WhatsApp, any form, any platform would do. It didn't have to be secure. Because this was a crisis and they needed to do something about it. And 83% of responders said that they used these platforms for their teledermatology with their patients. So that's very curious. And another study from the task force within the EADV on teledermatology, led by Elvira Moscarella et al. From the IDS also, they did a survey on teledermatology use, but also doctors' perspectives on this in times of the pandemic. And curiously, 54%, which was a quite high number, were using teledermatology before the pandemic, but it was a rather small number of the visits, less than 10%. But it's interesting to look at the people that weren't doing teledermatology before the pandemic, the 46% that weren't doing teledermatology, they actually started using it during the pandemic. 73% of these participants started using it, and they also changed the perception to a more positive attitude towards teledermatology, which was great to see. So before the pandemic, 47% of participants had a positive idea about teledermatology, and the attitude became positive for another 32%. So 80% are now positive to using teledermatology after COVID. And in this survey, they also noticed that 32% were using dedicated secure hospital platforms. And I'm guessing that they already had these in place prior to the pandemic, whereas others had to find solutions. And that's wonderful that they said, security, fine, I'm with it, I'm for it, but we have to do something now. We can't wait until we have a dedicated secure hospital platform in a few years. So 49% were using Zoom, WhatsApp, Skype, any method would do. In the US, this study with a rather large number of teledermatology visits, 2,755, they were doing a lot of visits because 8.6 out of 1,000 visits were being done with teledermatology before the pandemic, and 20 out of 1,000 were being done with teledermatology during the pandemic. And these were being done asynchronously or synchronously. So they were using live video synchronous, or store and forward teledermatology asynchronous, looking at images and getting back a little bit later with their responses. And curiously, less than 5% of these visits were converted to face-to-face visits. Of course, this was not only skin cancer, it was acne, psoriasis, eczema, any type of rash, etc. In terms of skin cancer surgery, and this was from a plastic surgery department, they looked at how teledermatology helped them find the patients that needed urgent surgery. And you can see the number of referrals dropped quite drastically, the orange line, and then increased during the pandemic. The number of face-to-face visits in gray here dropped almost to 0, and then slowly grew back, whereas simultaneously the blue line, teledermatology was increasing and then decreasing again, but still maintaining itself high because they were still finding the benefits of teledermatology during later stages of the pandemic in order to find patients that needed surgery now and not later. Of course, the diagnostic accuracy wasn't perfect. It wasn't as good as the face-to-face visits, but they were not delaying urgent surgery for any patients. So their attitude towards teledermatology in terms of triaging for surgery was very positive. In this study from the US, lessons learned about teledermatology during COVID, they were using synchronous teledermatology via telephone or video. Telephone were probably more for follow-up visits or asking about reactions to drugs, adverse events, etc. Whereas they noticed that 60% of teledermatology visits for lesions of concern, so lesions suspicious of being skin cancer, had to be converted to a face-to-face visit, but they still had a positive attitude towards this because they were still managing a lot of patients this way. Another study by Perkins et al. Later on concluded that a hybrid system using live synchronous video, but also storing forward teledermatology in order to be sending high quality images for lesions of concern would be better. And they found that total body skin exams were probably not appropriate for teledermatology. And this was also seen by several other authors. As was this case from Azabor et al., looking at patient and physician perspectives on teledermatology. And here you can see that physicians were using this a lot for acne, rosacea, psoriasis, eczema, etc., very frequently, and being able to manage the patient entirely or in conjunction with in-person visits in most of these cases. Whereas lesions of concern usually needed inpatient or in-person visits as well, whereas total body skin exams, again, not appropriate for teledermatology, as considered by 96% of the participants in this survey. Patients were quite happy with teledermatology and even more happy than the dermatologists, actually. And when asked about if their family member or themselves were more likely to choose a provider who offered video visits, 80% of the participants agreed with this statement. When asked if they did save time in terms of traveling, waiting for the visit, or taking time off work, 96% saved some amount of time, up to 2 to 4 hours in some cases. So this is also a benefit of using teledermatology, of course. Now, we can't just stop here. We have to continue on and move on and do even more. We have to secure the systems, of course, but fast-tracking teledermatology into dermatology trainee timetables was the title of this publication by Hussein et al. And I'm just going to read what they concluded because it really tells us everything we have to know about what to do next. Fast-tracking teledermatology clinics into trainee timetables is an essential step to prepare the trainee for life as a consultant. We need more education within teledermatology. It's really what we're doing here at the Congress, if you think about it. We're learning by looking at images, because it'll inevitably involve some aspect of regular teledermatology work in the years ahead. The COVID-19 pandemic has necessitated and hastened the adoption of teledermatology across the UK, and as you've seen, across the world. And doing so has sharply highlighted the effectiveness, flexibility, and overall importance of this practice. So learn teledermatology, don't be afraid of it, adopt it. It's here to stay. Thank you very much. Bye-bye.
Good afternoon. Thank you very much to the organizers for allowing me to speak today about direct-to-consumer teledermoscopy. I would first like to acknowledge the funding received for this study from the Australian National Health and Medical Research Council. And I would very much like to also thank the partners that were involved in this study, especially PhotoFinder, Princess Alexandra Hospital Foundation, Melanoma Patients Australia, Queensland Institute of Dermatology, Skin and Skin Cancer Foundations of Victoria and New South Wales, dermatology departments of the University of Graz, University of Arizona, and Memorial Sloan Kettering Cancer Center. We also received support from the Australian Cancer Research Foundation for the ASMIT study. So as you probably all are aware, melanoma is a very common occurrence in Australia. It's the third most common cancer that is diagnosed in men and women. The incidence of Australia is now 49 cases per 100,000 and is still rising. Also in the younger population age groups, there seems to be a drop in recent years, which is great news. So with regards to these rising rates, we still need to do more with regards to early detection of melanoma. And this is especially so because similar to other countries in the world, Australia does not have a population-based melanoma screening program. And the best advice currently to people is to do skin self-examination and to really look out for any spots or moles that they are concerned about and present to a doctor quickly if they do so. Here you can see our Australian Olympian Kate Campbell, who supported the Game On Mole campaign last year. So with regards to the skin self-examination, we were really interested to study the role of various new digital technologies. This includes mobile apps, but also consumer mobile teledermoscopy and also artificial intelligence algorithms. And I go through each of those a little bit in the next 10 minutes. So with regards to the skin cancer apps, it's an absolutely fascinating topic. There are so many different apps being developed with a number of different uses. So there are apps that really try to be educational and support people in their preventive efforts, such as in Australia, we have the SunSmart app, which tells people when to put on sunscreen and how to protect themselves daily. There are many apps that allow people to assess their risk of melanoma development. They often have validated risk assessment tools that have been developed from cohort studies and give quite a good assessment of risk. There are also apps that allow people to track and monitor lesions over time. So it's basically a tracker. So people can photograph a lesion that they spot during a skin self-examination this month and then follow up a month later to see how whether it has changed or whether it's still looking the same. And then there are apps that support the early detection of melanoma. And there are apps that help patients to communicate with clinicians. And then there are others that use automated algorithms to analyze those pictures. And if you look in the App Store, you can see that there are really hundreds of these apps available. So what I did here was just search for the topic melanoma in the App Store, and you can see the wide variety of options that are presented directly to consumers. So quite amazing. We did some reviews of those apps, 3 in a row, 2014, 17, and 19, to see what's out there, what's changing. And as you can see, there's quite an increase in the number of apps that we found that were eligible for our reviews. And we described various topics of importance to consumers, such as how much those apps cost, what reviews they get from consumers, and also what topic they cover. So if you're interested in this, please look at our reviews. We found that there was a change in not only the apps that were available, so some of them come and go over the years, while some stay present over the years. And you can also see that the most common functionality changed from mainly educational in 2014 to now monitoring and tracking in 2019. So we were really interested in particular those apps and mobile technologies that could support consumers in skin self-examination. These apps could also give us an opportunity for momentary ecological assessment. So how does spots or moles look when people image them themselves at home? And we also wanted to study this more because we did some preliminary data that indicated that consumers were really interested in such apps, and they would also be willing to pay for them. And of course, 2020 was another very important turning point with regards to our interest in apps, because they became so important during COVID-19 when virtual melanoma checks were basically the only ones available in many countries in the world. So what could be possible benefits of direct-to-consumer teledermoscopy? Of course, we know that dermoscopy helps clinicians to look really closely at lesions and get a much better understanding of their concerns. And this could also help people to check all their lesions and look closely at lesions more so than they usually do when they do a skin self-examination alone. because it would require photographing in hard to see areas. It could prompt partner-assisted skin examinations, which have been shown to be much more beneficial than doing skin self-examination. And then you could also photographically record your lesions and monitor and track them over time. And of course, the opportunity for telemedicine, very important. But no study to date has really looked at whether this helps people to pick the correct lesions, because it's easy to pick some, but are they the correct ones? So we embarked on a randomized controlled trial comparing skin self-examination without and skin self-examination with a mobile dermoscope at home. So you can see our intervention and control groups activities there. And we followed everyone for, we asked them to do 3 skin self-examinations and then to come back and do a clinical skin examination with everyone by a dermatologist. Here's our consort chart. You can see we randomized 234 participants, and we ended up with just around 100 participants in each of the intervention and control group for analysis. So this is what we asked the control group to do, to please note any lesions of concern on this body chart, and also to note down the level of concern and any comments that they had. And this is what we gave the intervention group participants. We specifically created a consumer-facing app on the Photo Finder platform, which people could use to note down the lesions, their concerns, where the lesion was, and to send it in to our dermatologist. So here are our results. Intervention participants submitted 615 lesions through this app, whereas control participants noted 673 lesions on their body chart. In total, we had 3 melanomas detected during this study. 1 each was found by participants in the intervention and control group, and 1 additional one was found by the dermatologist in a participant in the control group that was missed during the skin self-examination. Overall, we found 103 suspected skin cancers by participants and 24 additional other ones by the dermatologist at the clinical examination. And here you can see the sensitivity and specificity outcomes for lesions clinically suspicious as skin cancer detected by intervention and control participants. And you can see that sensitivity of control participants was a little bit higher than intervention participants at about similar specificity. So what could be reasons for maybe other results that could sort of help us to explain these results was that fewer intervention participants performed all 3 of the skin self-examinations that we asked them to do, and fewer of the intervention participants conducted a whole body skin check compared to control participants. But more intervention participants had help with by a partner. So in conclusion, what we found was that both groups achieved really high sensitivity and similar specificity when they looked at their own skin. This is the first RCT, to our knowledge, that really provides evidence for the value of skin self-examination and how well consumers can do when they look at their skin purposefully. There were no melanomas overlooked in the intervention group, which was really great, but we had a very small number of melanomas overall in the study. So a bigger study probably is needed to further confirm the benefit of mobile teledermoscopy for melanoma detection, given the relative rarity of this still even in the Australian population. So adding the mobile teledermoscopy in this particular study did not improve the sensitivity as we had hypothesized. And some of those reasons could be that it was too short a study period. The 3 months wasn't enough for people to really get used to the technology, and the technology might have distracted or taken so much time in those early periods that they didn't do a whole body skin check, and they also didn't do all 3 of the checks that we asked them to. And so I think a longer study is needed to be absolutely certain about those sensitivity outcomes. At the moment, given our results, naked eye skin self-examination is a really good thing to recommend to your patients, because it's obvious that people are very good at picking up the right lesions. And we need more work and bigger studies to finalize the benefits or to realize the full benefits. Based on our study, we compiled an imaging quality checklist for consumers, which was based on the standards for dermatological imaging that Clara Correa Lewandowski had developed. And we're currently validating this checklist for improvements in images that participants send us. So with regards to artificial intelligence apps, when we did our review, we found that the sensitivity of these apps ranged very widely, and you can see quite a bit below what our consumers achieved without AI. But maybe in the future, there could be benefits with regards to using artificial intelligence, especially to allow people to send pictures of maybe bigger areas of their body rather than individual lesions. And that would also alleviate a concern that clinicians often have with self-derived tools, because they could then see all the lesions that a person has on a particular body area and could be certain that there wasn't a melanoma overlooked right beside the lesion that was submitted. So I think the future for digital tools to support consumers in their skin self-examination is fantastic. And I think we should definitely invest more into more research with regards to this particular topic. It's very worthwhile. Thank you for your attention and looking forward to your questions.
Hello, everybody. My name is Paula Pasquale. I live in Spain, and I'm at the Pius Hospital of Valls. I'm closing basically the Congress, and I'm very happy to be here with all of you, and I thank the organizing committee for inviting me. I've been told to speak about the diagnostic concordance in teledermoscopy. And I have my only conflict of interest is that I'm a medical advisor for Dermocyte. Well, when I think about the title of this conference, I think that I've been asked to speak about the concordance between a dermoscopic diagnosis done through a face-to-face consultation versus a teledermoscopy image. And my first question is, why is there a difference? Is, you know, when you see a patient and you put a dermoscope, what you are getting is an image of that lesion through a dermoscope. And when you see the image that it's sent to you via teledermoscopy, it's exactly the same. It's still an image. So we are comparing and we are wondering why we need to have a concordance between two images that are the same. But still, and probably we need to know a little bit about the history of what happened in teledermatology. The first teledermatologies were done just using a clinical image. And somehow when somebody thought of including a dermoscopic image, which was the logical thought, since we all, and you know, people that have been participating in this Congress would never dream of not using a dermoscope to examine a patient, especially a patient with pigmented lesions, then it was thought of including not only a clinical image, but also a dermoscopic image. And you know, people that don't really like teledermatology thought, no, you cannot use a dermoscopic image to be included. I mean, just like that. And I know that in some countries, they have to show that this dermoscopic image was necessary, incredible as it sounds. So this group from Sweden had this paper, John Pauli is one of the authors, where they showed indeed that the teledermoscopy resulted in a higher diagnostic agreement, as it was expected, because you could make better triaging, and especially for malignant tumors, you were able to book directly to surgery all those tumors that you thought were suspicious of malignancy. So basically, the scenario we have when we do teledermatology is that we have, speaking about tumors, you have the single lesion consultation or a multiple lesion. When you have a single lesion, which is the ideal one, you get your clinical image, you get a few words on what that patient has, and then you get this dermoscopic image. This scenario, I think it's even better than having a face-to-face consultation. I know it sounds provoking, but I really think it's the best scenario, because one of the advantages, there are several advantages to teledermoscopy, and the main ones are this. You have time to analyze the lesion. When you have a patient in front of you and you do a face-to-face consultation, you only have a certain amount of minutes. In a public system where I work, I only have 8 minutes per patient, and I have to really go fast through all the pigmented lesions. When I have a teledermoscopy image in front of me, I can stay there all the time I want to analyze it. And if I still have doubts on that lesion, I can get second opinions, which is very important. And finally, you know, I can always, this can run through artificial intelligence, and I can even get only those lesions that are suspicious, and don't waste any time analyzing images that are obviously benign. But the issue with teledermoscopy and teledermatology is image quality. We need good image quality. And when we speak about medical photography, we need to standardize the images. And there are a series of things like the ones that I put there that are very important, that include focus, depth of field, color calibration, light, resolution, etc., etc. But when we speak about dermoscopic image, the interesting thing is that some things you don't even need to take care of, like the backdrop, the distractions on the patient's earring, things like that, because those will never come out on the image itself. And the first four, like focus and depth of field, color calibration, and white balance, light, and resolution, are basically taken care of by the unit itself, because we have a standardized light, standardized distance, and so those first four usually don't pose a problem. That is why dermoscopic images tend to be better than clinical images. And for those of you that have done teledermatology, you usually get a fantastic dermoscopic image and a very bad clinical image. And although you want your family physician to send great images on, you know, both clinical and dermoscopic, you make the diagnosis with your good dermoscopic image. There are three issues that are still pending, which are the field of view, the position, and the scale. And also the fact that you can always have a distortion on the images, like an optical distortion, and also in the so-called perspective distortion. In the case of dermoscopic images, you won't have optical distortion. You might have a perspective distortion caused by the way you apply the dermoscope on the skin. And then you can have a lesion that looks longer. You can have an orientation difference that makes it a little, you know, tricky to standardize it. This is just to show, you know, that I myself have made a video to teach patients, and it's a free video because it's important to train not only family physicians to take images, but we also right now need to train patients to take images. And the basic first rule is that we need crust to be taken out so that we can see what's under the crust, that we have to have two images, two dermoscopic images, one a little bit farther away to have the whole lesion, and then close-ups. For those large tumors, maybe we need several close-ups. And most dermoscopes include a scale, and it's important because I want to know if, you know, I have a tiny lesion, you know, that I can just ask the family physician to remove with a punch, or if it's a large lesion and I need to have the patient come in. Lighting dermoscopy is very important, and and we know, and you all know better than anyone after this Congress that, you know, for certain lesions, you better have polarized light and other non-polarized lights. And I always like to cite this paper. It's very old, but it's very nice and just shows the different lesions that you need with each type of light. In teledermatology, the papers by Dr. Moreno have, you know, he's a great teledermatologist and he has a lot of publications. And he has this article that has been published many years ago showing that teledermoscopy gives a great, is a great triage system for pigmented lesions in improving the diagnostic confidence level and the specificity of the referral and also the rates of referral. In a most recent paper and with this group where we can find names like Clara Priel and Dr. Sawyer and Monica Janda, we see that they have developed this checklist tool to assess the quality of skin lesions images, because what is important nowadays is that the images that we will be getting more and more since COVID are coming directly from the patient and not from the family physician. So we need to have checklist. And in this checklist that they proposed, the nice thing is that the 84% of the participants were able to select the image correctly. And also this checklist worked as a triage tool and improved the efficiency and accuracy of the teledermoscopic process, and also can be used to get feedbacks from the patients. From this group from Italy, they wanted to see the role of teledermoscopy using a very cheap unit and being able to classify the skin lesions. And nowadays we'll see more and more gadgets coming out that can be used directly by the consumer. So while many are still discussing if we can include a dermoscopic image, you know, there is a world that it's already selling to consumers their own dermoscopes, and we better start moving up fast, because in no time you will be getting images directly that you will, you know, get them through many different ways and apps. And now in this sense, many companies have come out already with these tiny units. Dermocyte is one that has had great experience with this screening system in pharmacies. And we have Canfield also that has this small unit that it can be attached to tablets or mobile phones. 3Gene with this tiny Dermalite HUD for patients, and also Photo Finder has this handy scope. Or this Barcodemetra, that it's a system that can be rented by family physicians to send images. This group again with Dr. Sawyer and Monica Janda wonder if is teledermoscopy really going to replace face-to-face examination? And basically they believe that trust is a crucial prerequisite for the adoption of teledermatology systems, and that most patients are satisfied about this. It's important also to realize that there is a an age difference. Of course, the younger people feel more comfortable with technology. We still have issues to solve with the older generation that have more malignant tumors, but maybe they are not so prone into using technology. In a paper from this Danish group, we see that using teledermoscopy increase specificity, while they did not find that it really improved on sensitivity. So what is the future on teledermoscopy? Well, we are moving into a world where we have patients become images. More and more, we'll see less and less face-to-face consultations. We are very close from getting equipments that will do total body dermoscopy. Patients will go into a place and have a total body dermoscopy, run all these images through artificial intelligence, select the ones that are suspicious, and you will get those images and you'll decide if the patient needs to come in or not. So this is the future and I'm very excited to be part of this and to see how we will be able to help more and more patients using teledermoscopy and teledermatology. Thanks again for the opportunity to be here.
Well, thank you. It's a great opportunity to be at this last session of this virtual meeting with great lectures. We would like to thank, of course, the organizers. We are very sad to not be able to be in Argentina, of course, but it was a very interesting session, and I hope everyone enjoyed it as I did myself. So I would like to say that for the moment, we have just one question from the chat, and this question is for David, and we'll ask this question later. But I have myself one question, and this one is for John. John, you showed that there are so many ways to use telemedicine in a crisis period, this crisis of the COVID, but probably not all of them are appropriate in terms of safety and in terms of security of the message transmitted. So could you make an overview of what are the regulations in Sweden and many in other countries for telemedicine and teledermoscopy in particular?
Yeah, well, thank you so much, Luke, for the question, and to all the speakers for their excellent lectures. As I mentioned in my lecture, of course, in times of crisis, you really don't care too much about security and regulations. You just have to get the job done. And in regards to your part of your question, where you're asking about the Swedish regulations and laws, then I mean, they're not too well regulated, and there's no real clear-cut laws. Of course, there's the Data Protection Act type of laws and personal information sharing. There's always a risk of hackers coming in and obtaining information from these systems. But then we have to kind of weigh this against the risks of health and patient life security, so to speak, and not being able to visit a doctor, I think, during times of pandemic is probably more dangerous than the security risk of perhaps finding a picture of a mole out there on the in clouds and on the internet, right? So I mean, I think, but one of the big issues for me, and what I thought was quite fantastic, was having done teledermatology and teledermoscopy for so many years, and seeing how difficult it is to actually implement systems and get hospital-based secure systems up and running. And even in the EIRIVI task force, as I showed, just about 30% of the people that were working in there had access to this type of system, where David's been a pioneer, and Amanda has been doing, working on secure systems and having these in place. But very, very few places in the world today have this type of secure system. And this is, I think, the main barrier to implementation. And I think David really touched on this in his lecture, the problem with implementation. And we've been working on this for 30 years, not me personally, but the group here and other people, pioneers, have been working on this for 30 years, and we're still not doing teledermatology enough in the world. And now during the pandemic, suddenly people just started doing it, and this was fantastic to see. And I think you really have to start getting people engaged in the system and then fix the bugs, and then fix the security issues and fix all that. But just start doing it, and then, you know, make it a problem, create the problem, and then you can find the solution. But if we just see the problems and the security issues, then nobody's going to implement teledermatology, or it's going to take 5, 10, 20 years more. And we just don't have the time to wait if we're going to have any improvements in healthcare. So yeah, in summary, the security is an issue. The regulations are an issue. They're important. They should be in place, and they should be implemented as well. But it's way more important, in my opinion, to implement any type of system to begin with, and then, you know, let the bureaucrats and the law enforcement and the lawmakers and all the administrators deal with the problem of safety and security. You know, that's not our job as doctors. I mean, of course, we have to respect it, but it's not our jobs to make sure that that's in place before starting to work and help patients, in my opinion.
If I may, John, I was not too much concerned about the images of naked people on the internet. I was concerned about responsibility in case of malpractice. Is there any kind of retrieving the opinions given in telemedicine in order to sue doctors if someone made a mistake, and how are the mistakes shared by the two actors in teledermoscopy or telemedicine in Sweden and maybe in New Zealand or Australia or India, everywhere? This could be a very interesting question.
Absolutely, and I think it's really an issue of where you're working. Of course, in the U.S., where everyone is getting sued all the time, at least this is the image that we hear about and get information about. That issue isn't as big of a deal in Sweden. In Sweden, it's very laid back. Of course, you can get sued, and there is malpractice, but it's really difficult. The authorities are more on the side of the doctors in general, because it's you really have to be proven guilty until proven innocent. I mean, you have to be proven guilty until you actually are sentenced, so to speak. Whereas in many other countries, I think at least the doctors that are working in certain systems are afraid of the system not protecting them. And that's not good, because then we get reluctant to using innovative systems. We get reluctant to trying to help patients, you know, worried more about ourselves than about our patients. And that's not a system that I would like to work in. And I don't think it's a system that our patients benefit from either, where the doctors are afraid of mistreating someone. I think we have to be given the liberty of gaining confidence in our diagnosis and trusting ourselves, and patients being able to trust us. So I think this is an issue that we have to work more with.
Thank you. Let's move to Australia and ask the question, how it goes when the patient is not referring the good lesion. Is there any concern about that? Because they are supposed to select the lesions to be transmitted, and how do you manage that in terms of responsibility?
I presume you're talking to me. New Zealand is not a state of Australia, believe it or not.
I'm sorry. No, I'm sorry. Of course.
I think that, of course, we can't do whole body skin examinations. And our response to that is every single teledermoscopy report comes out with, please examine your patient from head to foot and refer again with more lesions. Following John's comments about missing melanomas, it's in your face if you're a teledermoscopist, because your mistakes are visible to everybody else. On the other hand, the teledermoscopist is the most experienced in seeing skin lesions. We see hundreds and thousands of skin lesions, whereas the standard dermatologist can't possibly see in detail as many as we do. We are the most experienced and the most expert. And it is most important that we are teaching our trainees and it's very difficult to timetable, but essential that new dermatologists come out of training and they learn so much more quickly if you are offering that in your service, so that in 1/2 day we're seeing hundreds of lesions. I can't remember what your question was, Luke. It's 3 o'clock in the morning.
Well, maybe, Luke, I want to make a comment, and it's the fact that when we receive consultations from family physicians and we got them by a paper, we were still missing lesions. I mean, because it was the family physician who selected the lesion in any case. So I don't see the difference. I mean, now we're getting the family physician selecting the dermoscopic image. Then before we had the family physician send us a paper saying that the patient had, a dark lesion. So there is still always somebody selecting for us. And indeed, the utopically ideal situation would be that we would need to see the whole body of the patient. But it's just not possible. I mean, there are so very few of us in the world, and there are so many people that need to be examined that we definitely, I mean, the time will come when we get this total body dermoscopy. The patient can go to a pharmacy and get a total body dermoscopy, and with artificial intelligence, we'll select what we need to see. But otherwise, I mean, nobody can expect us to diagnose absolutely every melanoma on patients, because there is always a selection done.
David?
Sorry, sorry, Amanda.
I'd just like to comment that our family physicians' educational level on skin lesions is incredibly better than a few years ago, because they're also learning teledermoscopy and learning what to look for and what's important. Because part of our reports is teaching them how to take photographs, teaching them how to examine, teaching them what to look for.
Sorry, I had a comment about the previous questions about safety and security of pictures in the cloud, something like this. In Spain, what we have to be compliant is with general data protection regulations in Europe. This is the only not minor, but the only regulation we have to fulfill. But it's exactly the same that we have to also fulfill when we use a digital information record, digital clinical records at the clinic, or when we take pictures in our face-to-face practice. We must to take to get a consent form to take a picture in face-to-face practice. Is not very common to do so, but the general regulation in data protection oblige us to do so. So what we achieve to be compliant with this regulation is making our telemedicine platforms to be part of our general information system at the hospital. So that way we may fulfill these requirements. So like in digital clinical records, and so again here when we fulfill a teleconsultations to be submitted, the patient is asked to sign a consent form where he allows the transfer of pictures and the use of pictures for clinical and diagnostic purposes. So the regulations about data protection are exactly the same that we have to fulfill in our face-to-face practice.
So we had the answer for New Zealand, from Spain, for Sweden. How about Israel? Alan.
Look, thank you. I think in Israel there's been a position statement iterating some of these issues that you've talked about: compliance, safety, storage, etc. But I don't think it's enforced yet. I think it's still the rule is still the unofficial documentation. Obviously, we are all documenting lesions. We're all sharing images and asked about images both directly from patients and from colleagues. But there's a long way to regulation in this regard, and we all feel that. The COVID is, if anything, it's accelerated the share of information between the vendors and the patients and the physicians. Just as Sean Pally has said, and everybody's gave that priority over the regulations. But I think we all feel the urge and need to be more strict about these regulations. I have a question when you're done with your round of international about pink lesions.
Maybe we should move to India first and then your question.
So thank you, Luke. Thank you for the question. Now, the thing with India is we still follow HIPAA compliance. We follow the Health Insurance Portability and Accountability Act. But it's again, just like Israel, it's not enforced for us. So what we do is whenever, and in India, because we don't have a very high prevalence of melanocytic or keratinocytic borne tumors, what we usually do is we get second opinions and we usually get straightforward type of consultations. So I prime the physician who's sending it to me. Most often dermatologists who don't want to do dermoscopy, they send me the lesion and then I tell them what I want from the patient and exactly what I need to know. And that happens over a phone call without any transfer of images. But we do send a lot of images across on WhatsApp, which even though it's end-to-end encrypted, I feel it's a very bad practice because someday or the other, it might come back and bite us. So we're trying to kind of streamline that even now, but it's not enforced, at least as on date.
I will conclude by friends. We probably have the highest level of bureaucracy since it's strictly regulated. It has to be crypted. It has to be stored. We need to keep the files for 20 years. And of course, if the patient comes to the hospital, the telemedicine file record should come into the record of the patient. So it's a tough thing. We need also a contract between the requester and the expert. So it's a very tough thing. But having said that, it works. And the only thing is it adds some kind of technical problems, but not too much. But let's move to the next topic. And the next topic is concordance. I was wondering why we have so many studies studying the concordance between face-to-face and telemedicine. But since we usually in real life ask 90% of the patient to not come to us, how come we don't have real life studies of the concordance, not with the telediagnosis, but with the pathological or the evolution of the patient? And maybe it's a good idea to ask Paula about that.
Okay, there are certain studies. I mean, I think at the beginning there were many studies of concordance because we wanted to see if what you diagnosed with telederm was the same that you diagnosed in a face-to-face. And yes, there are some studies on that. And especially, I know David has papers that also where he could, he compared with the pathology. I mean, because after they did the surgery, they showed the concordance with the diagnosis that was made with the dermoscopy, which is the easiest actually study that can be done because you have the person come in and you do the surgery and then you can show that what you diagnosed was the same as you got out with the pathology. You still need to have to see what happened to those patients where you said it was benign and they didn't need to come in and you didn't do biopsy. To me, and this is going to sound a little bit philosophical, Luke, because I think you're not doing a biopsy on everything that you see face to face. So why do we need to do the same when you do teledermatology? This is something that, when you see a patient face to face and you think it's a set keratosis, you're not biopsying that lesion. I mean, you're just giving that diagnosis. And that possibility of making a mistake face to face exists with teledermatology too. And I don't think it's more with telederm. Probably that is the issue. People think that there is more possibility to make a mistake with teledermatology. I believe there is less possibility because you can have the opportunity to stay more time in front of that image and to get second opinions. And if that image it's blurry or you don't have a clear diagnosis, I always tell you have to see the patient. Anytime the image is not correct, anytime you feel uncomfortable or you don't feel sure, you have the patient come in. And that's it. I mean, it's just as simple as that. But just doing a correct telederm, people like David and John that do a lot, I mean, you get 70-80% of the people that don't even have to come in because you get the right diagnosis.
David?
It's a very nice, it's a very interesting, a very good topic. It's a key topic. Why face-to-face practice must be considered the gold standard. If we accept the gold standard to be the face-to-face assessment, where we are accepted indirectly that an in-person dermatologist is never wrong, or almost never. That's the issue. Applying the in-person assessment with accepting that there is no room for a mistake in an in-person, and that's not true. So as I've mentioned, we also make mistakes in our conventional face-to-face practice. The issue is the huge numbers of benign lesions that we manage, and that cannot be excised and studied by the pathologist just for research. And many local ethics committees do not usually approve this proposal for research. It has been carried out in very few studies with a very limited number of benign lesions, but it's the most we can do. So I do agree that the goal is there should not be the in-person assessment, and so any high quality study conducted must include a sample of patients as long as great as possible, both with benign and malignant lesions, with final pathological study for both, for benign and also for malignant. Yeah, and if possible, as following a randomized methodology and design. But not absolutely, I do not agree that the gold standard should be the in-person assessment.
John?
Yes, I think both Paola and David make great points, and it would be completely unethical to excise or biopsy every single lesion that we include in our teledermatology studies. So I think we have to find a kind of a combination of using the pathology when it's required, which is perfect, or perfect. I mean, that's our gold standard, at least. It's not perfect either. In cases where they're completely benign, perhaps consensus between several dermatologists doing independent diagnoses on the lesion. That would be ideal situations. It's going to be more expensive, more time consuming, but could be done. And of course, in atypical melanocytic lesions that are too benign looking to excise every single one. But if you want to make sure, then of course following up these lesions over time and having at least a midterm follow-up or monitoring of the lesions would give us a better standard to control the studies. But to excise everything and have a pathology report for each one, that will also include a selection bias, giving us too many malignant lesions in our studies, making it not really concordant with real life situations. So it's a fine line balance.
Thank you. Alan, you had the question.
Yeah, thank you, Luke. I was wondering about the teleconsultation on pink lesions. Whenever I see a pink lesion in the clinic and I take an image, I always find the image to be somewhat superior to what I'm able to achieve with my dermoscopic direct view in terms of the vessels. And I think also in the clinic, you also view the clinical aspect of the lesion. And this is reiterated by the study by Shandel et al. That showed the low accuracy on non-pigmented lesions. So I was wondering, how does this come into play? What is your perspective, and what is some of the checkpoints that you use in overcoming this limitation? I think many of the cameras are also less high quality in transmitting the red color in special, red and pink. So I would address all the speakers with that question.
We have published a paper on teledermoscopy, tertiary teledermoscopy from dermatologists to experts, and we have shown that in fact pink tumors were the field in which we were the less efficient, with a high number of discrepancy between our opinion and the final pathological diagnosis. So I agree, it's a very difficult thing. But as said earlier, we are not only experts on images, but we are also experts in photographs. And very often it is possible to tell our colleagues why the picture is not good and how they can improve the picture to get a better image. And in terms of pink tumors, I think the pressure is very important. Using a gel and not water or not alcohol for immersion is also better. But having said that, it's probably one of the most difficult fields we face in our tertiary telederm consultation. But I would love to hear what is, let's say, in India. What do you think?
So again, I think you're right about the pink lesions. Pink lesions are quite difficult to transmit, especially when they come as consultations. Mostly you'll miss all the signs. You'll see absolutely no vessels. It'll be like a blur of pink. Having said that, like I said before, we don't tend to see too many malignant lesions, especially which are melanocyte based. So that probably saves us most of the, the lawsuits and the action that we were actually talking about. But yes, pink lesions do seem to have a lot of problem. I do find that people who forward pink dermoscopic images to us, we don't really, it's very difficult for us to make a diagnosis. I can't even tell if it's benign or malignant sometimes.
How about Amanda?
Takes practice, certainly hard work with the pink lesions, but it is essential to have a regional view and a clinical view and dermoscopic views with and without pressure. And sometimes with a finger running across the lesion to see if a lesion compresses. I thought I might, with some of these discussions, just tell you about our current situation at Waikato Hospital. We've been hit by ransomware, which means that our teledermoscopy service, which is incorporated with our hospital service, went down with everything else 4 weeks ago. And we've been back to seeing people. We don't know whether they're coming because there's no information as to which patient is due this morning. But our teledermoscopy service was up and running within a week, whereas our face-to-face service is still not really running 3 weeks, 4 weeks later.
Interesting. And can you tell us why? Because in fact, seeing patients coming, why should you need to have everything about their background, especially for dermatology?
You have to have a booking system.
Okay. Okay.
So patients randomly turn up. We can't expect them. We don't have their notes. We have to say, we don't know your name. We don't know your disease. Are you here for a skin check or is it psoriasis?
Amanda, may I ask, how much are these pirates demanding? How much do they want? How many dollars?
Who knows? Who knows? But they're not getting it. But I have been, our email systems are still working. Interestingly, the only thing that is preserved is Microsoft Office. And so we're allowed to use Teams for our consultations. And the teledermoscopy service was quickly separated. And we've been able to continue that.
So if you would have it would have been more secure, and you would have avoided all the problems if you had, these non-secure, non-HIPAA compliant systems. It would have been better, and you would have saved a lot of time and money.
Yep.
Okay.
Yep.
It's terrible. Terrible. I hope you solved the problem.
Yeah. Well, many worldwide people have experienced the same and are helping my institution sort it out. And no, they're not paying the ransom.
As far as cybersecurity, worldwide, the systems that are mostly attacked are the health systems.
Well, I suppose it's time to ask the question to David. It was sent by the chat system. It says from Rubetta Matin, it says that it was a great presentation, and we all agree. A number of commercial companies are trying to exploit teledermatology by suggesting that artificial intelligence can improve this. I wonder, what are your thoughts, and if you see a potential role for artificial intelligence in teledermoscopy in your interface?
Yeah, it's a very, very good topic as well, but I have before I comment about the pink lesions and these tricky lesions, that obviously a pink lesions on teledermoscopy is a tricky lesion. But we use almost every day a quote that in teledermoscopy, in teledermatology, we do not attempt to achieve brilliant diagnosis, brilliant diagnostic, but proficient and good decisions. So in that case of pink, of nodular lesions, this type of teledermoscopic consultations takes no more than 30 seconds. You just open the image and the patient is referred to the clinic or to the operating room. So no, we shouldn't, at least if you connect with a primary care physician to triage and to select those patients to come to the hospital, do not attempt to make brilliant diagnosis by good decisions. About the artificial intelligence, I'm absolutely sure that it's playing a role in the future, and particularly in services working with not is going to be more in the side of the non-dermatologists using dermoscopy to help, for instance, family physicians in screening great workloads of lesions, or as an ancillary methodology to help dermatologists in tricky lesions, or also as a first test to be directly applied by patients using their cell phones with specific and commercial apps. What I'm convinced is that AI is a technology that will take part of the routine practice of the next generation of dermatologists. And also I see that teledermatology is a very appropriate methodology for AI and suitable to be improved by AI. What I'm not really sure neither is whether we should expect from an artificial intelligence algorithm to be sensitive, to be specific, or to have a good or the algorithm is trained. But what the melanoma incidence is low, as mentioned in the talk, so we would need that artificial intelligence algorithm raise a very low rate of false positive, and for that we should train these algorithms in detecting benign, clear-cut benign, better than malignant lesions, as they are very uncommon. Predictive value is a matter of prevalence that is very low, as mentioned, and this will improve with algorithms with a very high specificity. So I would train this algorithm, as I say, to be specific, and so to be able to detect, identify truly benign lesions, clear-cut benign lesions, and not to raise a great proportion of false positive. I am convinced that this will be part of our routine work in the near future.
Alan, we know that the computer technology is very advanced in Israel. Do you use a kind of triage with the artificial intelligence before seeing the teleconsultations?
So, not in my hospital, but I know there are some startup companies that are working on this, and they are trying to implement this in some of the HMOs. So the idea is to have the whole spectrum from guiding the patient on how to take appropriate image and have a Q&A on the image before it's sent to the provider. Then they're pilot testing the AI as a triage system to sort of the clearly benign, like David said, from the suspicious lesions. And then now everything is still referred to the dermatologist, but they are definitely playing with that idea of triaging pre-screening before referring to the physician to decrease the load on the consultations.
Thank you. Speaking about artificial intelligence, I was puzzled by the publication by Peter Sawyer's group on apps on mobile phones, on smartphones, since the sensitivity and the specificity of these apps is very little. Of course, I'm not speaking about transmission of images, but speaking about diagnosis. And we all know that young people trust their phone, their mobile phone, much better than they trust their parents, their doctors, the scientists, and the science in general. And don't you think we should have a message for these young people to probably get cautious, because there are many of these apps and probably it's possible to have wrong ideas of what is this lesion of concern. So what is your opinion? Should we do something, especially in areas where melanoma is very frequent?
If this question is addressed to me, yes, I've had encounters of patients knocking on your door to see you tomorrow urgently with an app that gave him a high score, and this was just a scratch, a hematoma, subcorneal bleed, etc. I think in some way this goes back to the sensitivity specificity trade-off that David was talking about. I think for the triage, the sensitivity should be very, very high. But then maybe there should be another app to check the specificity at the doctor's physician, at the doctor's office. Maybe one way to go would be a crowdsourcing of apps. You run the lesion through several apps and maybe together. And we've seen this in some of our AI studies, also in the ISIC, and also we are doing something like that in confocal. And we are seeing that each algorithm by itself is not giving the optimal decision, but if you combine the apps, they are covering for each other and giving a higher a sensitivity specificity value. So maybe that's another way to go.
Amanda?
I'd like to point out that actually I'd like AI as well. I don't want to miss any more melanomas. Blink and you miss it when you're looking at someone with 250 suspicious lesions. On the other hand, the very sun-damaged patients where there are 250 suspicious lesions, I don't want to be told by AI, that's a problem, that's a problem, that's a problem. So you need to be able to dial up or dial down, or simply turn it on for a particular lesion, depending on the circumstances. AI is here to stay. I'm not sure we're going to be able to prevent consumer apps. But we certainly need to educate our primary care physicians that just because the computer says it's malignant doesn't mean a human doesn't know better. So, because our experience is that because the app says it has to be removed, the primary care physician is saying, what do I know? I better cut it out.
I think that our role is not trying to fight against the apps. Quite on the contrary, I think we have to get involved and get involved in the development of apps. I mean, we are the ones that know what information we want, and we need to get involved on with engineers and work together and develop apps that will work for everybody, rather than waste our time telling people, oh, don't use this or don't use that, because like Amanda said, you're just wasting your time. I mean, this is like a tsunami of apps that will come out, in the following years. And it just makes no sense to be, running after your patients and telling not to use this or not to use that. But on the contrary, I try, for instance, in my case, I try to give advice to those companies that have approached me, saying what we as physicians need, because they'll take care of the rest. I'm not an engineer. I don't know how to develop those apps, but I want them to develop a good product, because I want that, people get access and have a way to reach to me if they need to, me saying a dermatologist. I want patients that need a dermatologist to be able to come to a dermatologist fast if they really have a melanoma. And of course, by doing that, like David's paper once said, you will get a lot of, subkeratosis too, because, you're getting more and more images, but I prefer 100 sub-Ks than one missing melanoma.
John?
Yeah, I mean, I agree with everyone. And but I think returning to your original question, Luke, perhaps instead of reaching out to patients and the general public, which is very hard to reach and to convince, we might have to reach out to our colleagues. And if we were telling them before that dermoscopy and teledermoscopy was important, it's going to be even more so in the future. And we have to build their confidence levels. to be able to avoid unnecessary excisions, avoid unnecessary worries from the patients when they've done their Google image analysis, and it's already out there. I mean, so it's too late, you know. We just have to make sure that our colleagues are confident enough, have enough education, have enough experience with teledermoscopy to be able to explain to their patients that what the AI said or didn't say is or is not correct in this particular case, and make sure that they feel our trust, or they trust in us.
I think, if I may add, I think the best way forward would actually be to feed these apps and to actually collaborate more with a few people whom you trust. Give them a lot of clinical images, as many as you can. And a lot of people do ask for unsecure images which you can use as Creative Commons. So to feed an app so well that the machine learning is of such high caliber that it can actually diagnose things properly, and then direct people towards only one app. I think that would be the way forward. Telling people not to use apps is long gone by. We have so many apps for clinical images in India. Anybody can download and mistake a psoriatic lesion for something as simple as a dermatophytic lesion, and many mistakes. So I think machine learning would be the way forward. There's no way we can prevent it.
Thank you. We have less than 10 minutes to go, and I would like to change the topic. We were in another session with John earlier today, and well, the main idea was the fact that as hyper specialist of pigmented lesions, we follow many patients with so-called high risk of melanoma, and these patients are creating a waiting list for dermatology consultations. And we all thought that dermoscopy and teledermoscopy can help to jump over this waiting list in case of a suspicious lesion sent by a general practitioner. So could you tell us how you are organized to fix that problem and to have a patient with a suspicious lesion back in your office the next week if you believe that it is absolutely necessary? And we make a round table, and we begin with New Zealand.
Very difficult. The surgical wait lists are organized by surgical people, not by diagnosing people. And we have a system where they're scored, and a melanoma scores 100, and a squamous cell carcinoma 95, and so on. And the scoring system results in the wait list. But still, people with pink lesions are waiting 6 months to learn that their pre-diagnosed basal cell carcinoma was actually a melanoma. And I'm not sure that we can ever get away from those mistakes.
Well, thank you. India?
So, like I mentioned, patient-initiated teledermoscopy is very rare in India. But yes, it does become a problem if I want to see a patient again, or if I want a repeat consultation, because it's always dependent as a second opinion. I don't get patients who come directly for a teledermoscopic consultation. Most of Indian patients do not have dermoscopes. They don't even know how to click photos. So we actually have a few innovations like drop dermoscopy and tape dermoscopy, which Dr. Bloom had famously published. But having said that, it's very difficult to track patients because they're actually second generation patients. They're not yours to begin with. So it's kind of a second opinion that you get. So it's difficult to track. I can't find a way around that.
How about Tel Aviv?
So yeah, that's a huge problem. I think the study that Monica showed emphasized that skin self-examination is not a very, at least in my country, it's not a very efficient tool. So I'm asking the patients, did you notice any change? They say, that's why I come to you. For you to tell me, I'm trying to lift the responsibility from me to you. But on the other hand, they are finding lesions of concern between the visits. And so the way they're working that is they're taking clinical photos, usually not with the apps, and sending you by email. If you have their total body photographies, you can compare and see if that's good, if that's not changed. In some cases, you can really see something of concern and have them come in the next day. Many cases, you would think, yes, it's probably a seb-care that's more irritated or a hemorrhage, but often the quality of the images that the patient sent is not good enough. And that's something that you have to go back and forth. The patients take selfies. In my opinion, selfies for clinical examination is not the way to go. Somebody else should take a picture of you, good lighting. I usually like them to take from several angles to get a good feel of the clinical. Take a clip of the hairs. We saw in some of the teledermoscopy images in the presentation, a lot of hairs, and I think that's detracting a lot of the focus and the light. So yeah, that's a huge challenge, but I think the skin self-examination is not the way to go. Probably it will be more booth that the patient goes in and tells you what's suspicious, what's changed, and then refers to the dermatologist. Otherwise, they still have to come in for the total body examinations if we're talking about the high-risk phenotypes.
Paula? Microphone. We don't hear you.
Yeah, sorry. Since I work in a small hospital, I do get the opportunity to schedule my own patients. So when I see them through telederm, I can schedule them immediately, 24-hour, 48 hours maximum when I think it's a melanoma. And indeed, in my experience, which was similar to the one in Seville, David, I think it was that with COVID, we had like a span of 2 months where people were not diagnosed simply because they were not sending images. But then all those patients that were high risk came anyway. So my number of melanomas just are the same. Actually, this year I've diagnosed more melanomas because at the end, all the family physicians started resending all the images they had not sent at the beginning. And people could be rescheduled, as they were being done before. I just, for people that are listening to our discussion, although I love teledermatology, it's not substituting face-to-face, it's a complement. It's a complement that will help you reduce the huge amount of people that we need to see because there are very few of us. And we need to definitely not waste our time seeing patients that do not need to come to us. I mean, that's why I love teledermatology because, I need to see in theory. I mean, I went to work in a hospital where I had a 3,000 people waiting list. I mean, it was impossible to manage until I got telederm. And now I have no waiting list because I do triage and I use my time on those patients that really need to be seen by me. And all the rest, like I say, goodbye. I don't want to see subkeratosis. And I don't want to see, seborrheic dermatitis. Somebody else can see that. I just want my family physicians to be trained and send me anything that is suspicious, and then I take care of those patients and give them the right time they need.
John, in 1 minute.
Yeah, well, a lot of ideas have been said, but another thing I think is really decreasing the number of unnecessary excisions. We've talked about getting the patients to the clinic and making the diagnosis and prioritizing and triaging, but then it also comes to surgical operation times. Paula's also a big fan of cryosurgery, and we're doing excisions on tons of BCCs on the trunk and low risk areas where we could be doing destructive therapy, which is, you can do it in 5 minutes instead of 30 minutes in the OR. Short-term monitoring of atypical melanocytic lesions that are flat, low risk patients, monitor, avoid excisions. So this is my small contribution in 1 minute.
David, you're a skin surgeon, so what do you do?
We work in a digital center where 2 or 3 dermatologists a day are fully dedicated to all the teleconsultations we receive. We receive about 150, 180 teleconsultations a day. As soon as any of these dermatologists detect any suspicious lesions or clear-cut lesions suitable to be directly operated, is referred to the surgical room in less than 7 days. If there is suspicious, it's not a simple lesion. This is referred to our face-to-face clinic also in less than 7 days. And all these referrals are managed by our staff. So there is little chance to have mistakes in these appointments.
Thank you. I think it's about to end. So I will not tell you how we do in our department. Maybe we have to organize another session about teledermoscopy to explain that. I would like to thank you all for this very nice meeting. We had a very interesting conversations to each other. Again, send all my apologies to Amanda, because I was confusing at the beginning, maybe because flag. And thank you very much for all to be here. And I suppose we have all to move for the closing ceremony of this meeting. Thank you very much and have a good day. Or good.
Thank you very much.
Thank you. See you soon. Bye bye.
Bye.
Thank you.
Take care.
See you.